Halo, Dr. Philip.
Eh, Halo pagi Pak, apakah bisa saya putarkan video penggunaannya sekarang Pak?
Ya, bisa silakan diputarkan dan juga peserta apakah bisa di-admit Pak Pandu para peserta untuk bisa join masuk ke dalam room?
Yeah. Good morning,
Baik,
Pak
nanti
Akim.
kita
How are you?
Oke.
Very good morning, Pa. I'm well. How are you?
I'm good. Thank you for joining on a Saturday morning.
No
Also-
problem. No problem. Thank you, Pa Pandu, for organizing this on a Saturday morning.
ya.
Also,
Good morning,
Philip,
Pak Akim.
Pak Philip
Good morning, Pa Ardianto.
already joined.
Yeah.
Pak Tio is from Gajah Mada University. Pak Raymond and Pak Philip from SEAL Asia, Manila.
Perfect. Thank you. Thank you very much. Good morning, gentlemen.
Yeah. And we'll join also in a minute our partners Aldilas is also from the Universitas Gajah Mada. Thank you, Pak Akim.
Great. Thank you very much.
Katagonia's Guide for Zoom Users. Panduan Katagonia untuk pengguna Zoom. Saat ini, host atau admin sudah mengaktifkan fitur interpretation. Bapak Ibu dipersilahkan untuk menggunakan Zoom versi terbaru agar fitur interpretation dapat bekerja dengan baik. The host has activated the interpretation feature. Ladies and gentlemen, you are expected to use Zoom. Please install the latest version for the interpretation feature work well. Please go to www.zoom.us/download. Mohon Bapak Ibu menonaktifkan mic atau mengklik tombol mute apabila tidak sedang berbicara. To help today's meeting run smoothly, please mute when you are not speaking. Jika Bapak Ibu ingin mendengarkan terjemahan dalam bahasa Indonesia, klik Interpretation, pilih Indonesian. Anda tidak perlu pindah channel saat berbicara. Jangan khawatir, pembicara dan interpreter dapat mendengar Anda. If you'd like to listen in English, click Interpretation, then choose English. You don't need to change channel when speaking. Don't worry, the resource person and the interpreter will be able to hear your voice. Untuk pengguna Zoom Mobile, klik More untuk masuk ke pilihan berikutnya. Pilih Language Interpretation. Lalu pilih Indonesian untuk bahasa Indonesia. For Zoom mobile users, click More to go to the next choice. Then, choose Language Interpretation. Then, choose English for English. Mohon dipastikan bahwa Bapak Ibu sudah memilih salah satu bahasa yang akan digunakan. Karena jika Bapak dan Ibu tidak memilih, suara Bapak dan Ibu akan mengganggu pembicara dan proses penerjemahan. Terima kasih atas perhatian dan kerjasamanya. Please make sure that you have selected the correct language for not making any noises for both speakers and interpreters. Thank you for your attention and cooperation. Jika ada kendala mengenai fitur ini, silakan hubungi host yang sedang bertugas atau hubungi IT support. If you have any technical problems regarding this feature, feel free to chat the host on duty. Thank you.
Hello, good morning everyone. Terima kasih banyak, selamat pagi. Terima kasih banyak telah bergabung di dalam diskusi kita pada pagi hari ini. Selamat pagi kepada para pembicara, kepada para narasumber dan juga para moderator yang telah hadir, dan juga termasuk para peserta yang bergabung pada diskusi kita pada pagi hari ini. Ya, sebelum kita mulai acara, izinkan saya untuk membagikan layar saya terlebih dahulu. Ya, baik. Baik. Jadi Bapak Ibu, kita ketahui bersama, perkenalkan sebelumnya, nama saya adalah Dr. Hardantio, PhD dari Pusat Kebijakan dan Manajemen Kesehatan, Fakultas Kedokteran, Kesehatan Masyarakat dan Keperawatan Universitas Gadjah Mada, dan juga perwakilan dari World Bank yang akan bertindak sebagai moderator acara kita pada pagi hari ini. Kegiatan pada pagi hari ini merupakan kerjasama bersama antara Pusdatin dan juga DTO, dan juga dengan World Bank sebagai bentuk dukungan dari World Bank dalam upaya untuk percepatan penanganan COVID-19 di Indonesia. Kegiatan hari ini, Bapak Ibu, seperti tadi sudah kita saksikan bersama ya. Jadi kegiatan hari ini akan bersifat bilingual antara Inggris dan Indonesia. Kami juga telah menyediakan 2 orang interpreter bagi peserta yang ingin mendengarkan materi dari pembicara dalam bahasa Indonesia atau bahasa Inggris. Maka dari itu saya mohon izin kepada para pembicara untuk saya dapat membawakan acara ini dalam bahasa Indonesia. Ya. I apologize for the every speakers that I will explain the sessions in Bahasa so that everyone will able to have more understanding about the activity that we will perform in Indonesia. Would it be okay for you, Mr. Achim, Mr. Raymond, and also Mr. Philip? Yeah, thank you very much. Ya, jadi kegiatan hari ini, Jadi Bapak Ibu bersama, kita ketahui bahwa dalam situasi pandemi COVID-19 ini terdapat kebutuhan mendesak untuk kita bisa mengintegrasikan sistem informasi seperti pengujian laboratorium, surveillance penyakit, dan juga fasilitas pelayanan kesehatan, terutama yang ditunjuk sebagai fasilitas rujukan COVID-19 untuk kita bisa menghasilkan informasi secara tepat waktu, real time, dan juga akurat bagi pemerintah, serta menginformasikan publik sebagai bagian dari strategi untuk komunikasi resiko. Dan Kementerian Kesehatan telah kita ketahui bersama telah membentuk DTO ya, Digital Transformation Office, yang terdiri dari para ahli, analis model bisnis, developer, dan programmer yang direkrut untuk mempercepat proses transformasi sistem informasi kesehatan yang ada di Indonesia yang saat ini masih terfragmentasi satu sama lain. Jadi saat ini kita sudah mengenal adanya berbagai standar interoperabilitas ya, seperti dari LOINC, Sonomed City, dan juga HL7. Tetapi memang masih belum ada standar yang diakui dan diterapkan secara nasional. Jadi tujuan dari kegiatan kita hari ini adalah kita akan meningkatkan kapasitas dan juga mengetahui gambaran kebijakan tentang standar interoperability yang akan bisa kita pakai di Indonesia untuk kita mempercepat tujuan transformasi sistem informasi kesehatan. Baik Bapak Ibu, jadi sebelum kita mulai, saya akan menjelaskan terlebih dahulu tentang rangkaian kegiatan apa saja yang akan kita kerjakan dari Pusdatin, DTO, dan juga World Bank hari ini. Jadi terdapat 2 rangkaian kegiatan Bapak Ibu. Jadi kegiatan hari ini adalah pertemuan di mana kita akan membahas tentang kebijakan standar interoperabilitas sistem informasi kesehatan di Indonesia. Dan yang kedua adalah workshop teknis untuk kita bersama-sama menyelesaikan use case untuk menyelesaikan kasus interoperability antara rekam medis yang kita punya di rumah sakit dengan rekam medis elektronik yang dimiliki oleh pemerintah. Ya, jadi Bapak Ibu, untuk workshop pertama nanti akan kita hadiri bersama dengan instansi pemerintah, baik badan maupun direktorat yang ada di lingkungan Kementerian Kesehatan, di rumah sakit vertikal termasuk di BPJS Kesehatan. Sedangkan untuk workshop kedua akan bersama dengan pengembang sistem informasi rumah sakit serta rumah sakit swasta. Seperti itu Bapak Ibu. Jadi nanti waktunya nanti akan berbeda dengan jumlah peserta yang cukup sangat terbatas sekali. Jadi nanti sistemnya akan kita undang kepada Bapak Ibu untuk bisa mengikuti workshop teknis ini. Baik. Untuk kesempatan kali ini kita akan mendengarkan materi dan berdiskusi mengenai kebijakan bersama dengan narasumber kita. Yang pertama adalah Mr. Achim Smilen selaku Program Leader of Human Development dari World Bank. Kemudian akan bergabung juga bersama kita Dr. Anas Ma'ruf, MKM, selaku Kepala Pusdatin dari Kementerian Kesehatan Republik Indonesia. Dan akan bergabung pula Bapak Setiaji, STMSI, selaku Chief Digital Transformation Office dari Kementerian Kesehatan Republik Indonesia. Dan akan hadir pula juga dua expert kita tentang interoperabilitas standar sistem informasi. Yang pertama akan ada Philip Christian, MSc PhD dari University of Philippine Diliman dari Filipina, dan ada Dr. Raymond Francis Sarmiento selaku Director of National Telehealth Centers dari Kementerian Kesehatan di National Institute of Health di Filipina. Baik. Berikut saya sampaikan rundown untuk kegiatan kita. Jadi hari ini kita akan berdiskusi ya tentang kebijakan. Kemudian setelah itu kita akan ada rangkaian workshop untuk instansi pemerintahan pada setiap hari Sabtu pada pukul 8 pagi. Nanti dari pagi hingga siang hari selama 4 minggu ya. Kemudian nanti di akhir Desember nanti kita akan ada workshop untuk gelombang kedua yang membahas materi yang sama, dan nanti kita akan menyelesaikan use case penggunaan FHIR sebagai sistem interoperabilitas yang akan kita pergunakan. Baik Bapak Ibu, berikutnya mungkin nanti kita akan ada paparan dari Pak Achim Smilen selaku Program Leader Human Development dari World Bank, dan juga pembukaan dari Pak Anas Ma'ruf selaku Kepala Pusdatin dari Kementerian Kesehatan Republik Indonesia. Kepada Bapak Achim Smilen, saya persilahkan kepada Bapak untuk bisa menyampaikan paparannya. Silakan Pak Achim. Ya, please, Mr. Achim.
Thank you so much, Pak Hatanjo, and good morning, selamat pagi, dan selamat sejahtera, everyone. I'm really privileged to give some short opening remarks at the beginning of this webinar on interoperability standards to support Indonesia's health information system integration. I would in particular like to welcome our friends and partners from the Ministry of Health, including Pa Anas Ma'ruf as the head of Pustatin, as well as Pa Setiaji as the Chief of Digital Transformation Office. And we'll be hearing from both of them very shortly, and they're very eager to do so. And I would also like to welcome Dr. Philip Zuniga from the University of the Philippines and Dr. Raymond Sarmiento from the National Telehealth Center, UP Manila. And again, we're very privileged to have such distinguished speaker and look forward to learning from all of them. Ladies and gentlemen, excellencies, all workshop participants, let me make three short points to set the stage, so to say, to frame the discussion before we delve into the more policy discussion today, and then of course also use this as a basis for the more technical trainings for government officials in coming weeks. First, as we all know, as Indonesia has been affected by the COVID-19 pandemics, like many other countries around the world, it is in fact using this pandemic as an opportunity to improve and to strengthen its health system. We've been very impressed to see that the Ministry of Health in particular has identified healthcare technology transformation as one of the main pillars of its reforms, and in turn, digitalization of the health information system is a main feature of this reform. In fact, during the COVID-19 emergency response, the ministry has integrated various information sources that are key for the pandemic response, such as laboratory testing, disease surveillance, and healthcare facilities. And this has been a critical part of Indonesia's response to COVID-19. In turn, the integrated system encompasses various units within the Ministry of Health, They collect information from a vast health service network throughout the country. The system has been producing information for the government to inform policy-making processes and to the public as a part of the risk communication strategy. So it is very encouraging to see the detailed information that is already available to the public in real time, which is really a good practical example from Indonesia that we can all showcase and highlight well beyond the country's borders. So while there's been a lot of progress, a lot of notable initiatives worth showcasing, my second point is that there's still more work to do. In particular, the integration of information systems as part of the health sector's ambitious digital transformation initiative will require a clear strategy and the good health data management and the establishment of interoperability standards, as we will be discussing today. While this is a difficult agenda, it can be very rewarding as well. It will enable us to extract more valuable information. But what it will require is really ensuring the availability of human resources with knowledge and skills for the integration of various information systems in accordance to these interoperability standards. Again, we'll be discussing more about this today. Third and finally, the World Bank is truly privileged to be a partner in the government of Indonesia's pandemic response, in particular through our flagship Indonesia Emergency Response to COVID Program for Results operation and its additional financing. Today's webinar and the ensuing training are complementary knowledge support that in fact form an integral part of the Program for Results and the World Bank's broader overall support to Indonesia and to helping the country master the COVID-19 pandemic. With that, we are very pleased to continue our support to the government of Indonesia's health transformation agenda, including in the space of digital transformation. Once again, I'm very pleased and honored to be opening this webinar. Look forward to a very fruitful discussion today, and I'm very eager to hear from our experts. Thank you very much. Terima kasih banyak.
Yeah, thank you very much, Mr. Achim, for your speech. Ya, terima kasih. Jadi yang kita ketahui bersama dari Pak Achim tadi ya, bahwa pada kali ini kita ketahui bersama bahwa saat ini sistem informasi yang berada di sistem informasi kesehatan yang berada di Indonesia masih terfragmentasi satu sama lain. Sehingga dengan adanya inisiatif ini, kita ingin bersama-sama bisa menyatukan sistem informasi yang masih terpisah-pisah tersebut hingga nanti kita bisa menjadi satu dan kita bisa saling menginteroperabilitaskan antar sistem informasi yang ada di Indonesia. Dan tentu saja itu memerlukan adanya sebuah kebijakan untuk bisa melihat standar informasi apa yang nanti akan kita gunakan secara bersama-sama di Indonesia. Seperti itu. Seperti tadi yang sudah saya sebutkan, ada cukup banyak sistem informasi standar sistem informasi yang bisa kita pakai, dan dari berbagai standar tersebut pada saat kita melakukan diskusi, kita menemukan bahwa HL7 Fires itu banyak sekali dipergunakan di berbagai negara dan sudah diadopsi juga oleh WHO melalui interoperabilitas untuk verifikasi vaksin di dunia untuk penerbangan internasional. Jadi ini menjadi kesempatan baik bagi kita untuk bisa sama-sama kita mempelajari bagaimana sistem HL7 Fire itu bekerja dan bagaimana kita bisa menyelesaikan use case dari interoperabilitas dengan menggunakan HL7 Fire ini melalui workshop yang nanti akan kita lakukan. Baik, untuk berikutnya mungkin kepada Pak Anas selaku Kepala Pusdatin untuk bisa membuka acara kita pada pagi hari ini, atau mungkin pada staf yang mewakilinya mungkin. Ya, Baik, tampaknya Pak Anas masih belum bisa bergabung pada pagi hari ini. Jadi nanti kita akan mungkin bisa masuk terlebih dahulu untuk kepada materi. Bagaimana Pak Pandu? Apakah kita bisa masuk kepada materi dahulu atau nanti menunggu Pak Anas untuk bisa bergabung, Pak Pandu?
Mas Tio, mungkin terima kasih Mas Tio. Mungkin
Ya.
dicek, saya lihat ada beberapa staf dari Pusdatin, mungkin bisa di-cross-check dulu sampai kita menyiapkan presentasi materi.
Ya, baik. Mungkin kita tunggu dahulu ya, mungkin kepada Pak Anas.
Mungkin
Ya.
2 menit untuk cross-check, kemudian kalau tidak ada bisa kita teruskan.
Ya, baik Pak. Mungkin kita akan menunggu dulu selama 2-5 menit untuk menunggu Pak Anas bisa bergabung. Ya, bagi para peserta, jadi nanti mungkin bisa menunggu sebentar selama 5 menit ya, untuk kita nanti menunggu Pak Anas bisa bergabung dalam diskusi kita pada pagi hari ini untuk membuka acara. Ya. Mr. Achim, maybe we will wait around 5 minutes before we begin the activity for waiting for Pak Anas opening remarks from Pak Anas. Ya, sembari kita menunggu dari Pak Anas, jadi mungkin kepada para peserta yang baru bergabung, silahkan Bapak Ibu bisa memilih untuk fitur interpretasi di bahasa Indonesia di bagian bawah. Jika ingin mendengarkan kegiatan kita ini dalam bahasa Indonesia, nanti rekan kami akan membantu untuk melakukan interpretasi secara langsung dari Inggris ke bahasa Indonesia. Dan sebagai latar belakang mungkin saya menjelaskan sekali lagi ya untuk kegiatan kita pada pagi hari ini. Jadi kita ketahui bersama bahwa di dalam situasi pandemi COVID-19 terdapat kebutuhan yang mendesak ya untuk kita bisa mengintegrasikan satu sistem informasi dengan sistem informasi yang lain. Karena kebutuhan data yang kita perlukan secara real time sangat banyak. Dan dengan adanya COVID-19 ini menjadi katalisator bagi kita bersama untuk mengetahui bahwa interoperabilitas antar sistem informasi itu sangat penting untuk mengurangi beban tenaga petugas kesehatan yang ada di masyarakat dan tentu saja mengurangi adanya duplikasi data, sehingga data yang bisa kita dapatkan baik dari sisi pemerintah maupun sisi swasta, datanya akan menjadi akurat karena sumber informasi yang kita dapatkan adalah satu dan tunggal. Dan kita ketahui juga bahwa Kementerian Kesehatan baru saja telah membentuk DTO ya, Digital Transformation Office, yang mereka telah merekrut banyak sekali programmer, developer baru untuk bisa mengintegrasikan proses sistem informasi kesehatan yang ada di Indonesia. Dan tentu saja saat ini untuk proses pengintegrasian tersebut kita ketahui bahwa ada banyak sekali standar interoperabilitas yang ada di dunia, baik itu LOINC maupun SNOMED City atau dan juga HL7. Tetapi memang masih belum ada standar yang diterapkan secara nasional di Indonesia, baik secara kebijakan maupun secara peraturan, secara praktek yang kita gunakan di Indonesia. Jadi dari berbagai standar tersebut, HL7 FHIR atau Fast Healthcare Interoperability Resource itu banyak sekali digunakan oleh berbagai perusahaan dan juga oleh berbagai negara untuk menyelesaikan use case interoperability mereka. Jadi seperti perusahaan dari Google, kemudian ada Amazon, kemudian Apple, mereka menggunakan FHIR. Seperti contoh Google, mereka menggunakan HL7 FHIR ya di dalam program Google Healthcare mereka. Kemudian Apple juga sama, mereka menggunakan HL7 FHIR untuk menghubungkan Apple Health app pada dengan Apple Watch maupun dengan rekam medik elektronik dari Apple tersebut. Maka tujuan kita pada 2 kesempatan hari ini dalam webinar kebijakan standar interoperabilitas sistem informasi dan juga nanti ada workshop teknis interoperabilitas sistem informasi kesehatan dengan menggunakan FHIR. Nanti kita akan belajar bersama-sama mengenai bagaimana kita menyelesaikan use case dalam sistem informasi menggunakan HL7 FHIR. Mungkin ada informasi terkait Pak Anas sebentar. Kita masih mencoba menghubungi Pak Anas sebentar ya. Pak
Iya, izin Pak Anas masih di jalan, Pak Tio.
Baik.
Bisa dengar Pak Tio? Ya, masih
Baik.
di jalan ya.
Jelas,
Apakah berkenan menunggu beliau atau ya? Beliau sih menyampaikan kalau tidak ya mungkin kita bisa mulai saja atau mungkin saya menyampaikan paparan beliau, bukan paparan ya, opening remarks beliau kalau memang harus berjalan begitu. Bagaimana Pak Tio?
Baik, Pak Rudi, mungkin bagaimana Pak Pandu? Apakah kita menunggu Pak Anas atau Pak Rudi bisa menyampaikan opening remarks dari Pak Anas?
Kalau misalnya Pak Anas masih dalam perjalanan, mungkin ada baiknya kita minta Pak Rudi untuk menyampaikan atas nama Pak Anas ya, lebih supaya kegiatannya bisa berjalan. Terima kasih Pak Rudi.
Nggak tahu saya.
Baik, ya silakan.
Kenapa Pak? Untuk sekjen sudah, pointers kan sudah, kan bersamaan dengan surat.
Baik, silakan Pak Rudi. Silakan Pak Rudi. Mungkin bisa di-unmute Pak Rudi. Belum terdengar suara dari Bapak.
Izin, apakah sudah terdengar?
Sudah Pak, sudah.
Ya. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Shalom, Om Swastiastu, Namo Buddhaya. Yang saya hormati tim dari World Bank, ada Bapak Achim Smilen, Program Leader Human Development World Bank, Bapak Pandu, kemudian Bapak Ibu sekalian dari World Bank. Yang terhormat kepada Bapak Setiaji, Chief of DTO Kementerian Kesehatan, para narasumber dan para peserta webinar. Bapak dan Ibu, pertama-tama marilah kita panjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala, karena atas rahmat dan karunia-Nya, walau masih dalam suasana pandemi, kita masih dapat bertemu secara virtual untuk berbicara tentang kebijakan standar interoperabilitas pada sistem informasi kesehatan, khususnya dengan FHIR. Saya bahagia sekali karena Bapak Ibu narasumber dari berbagai negara dapat bergabung dengan kita semua, termasuk dari Filipina, kemudian juga Bapak Ibu dari seluruh Indonesia dan unit di Kementerian Kesehatan dapat bergabung dengan kita semua untuk menyampaikan konsep dan pelaksanaan standarisasi di bidang sistem informasi kesehatan, khususnya tentang HL7 dan FHIR. Bapak dan Ibu yang saya hormati, Satu Data merupakan inisiatif dari pemerintah pusat untuk memperbaiki dan meningkatkan kualitas data kelola data pemerintah. Pemanfaatan data tidak hanya digunakan untuk pengambilan keputusan, namun juga sebagai akuntabilitas dan pemenuhan kewajiban pemerintah kepada masyarakat terhadap transparansi data pemerintah. Data yang disampaikan kepada masyarakat harus sama dan dapat dipertanggungjawabkan kebenarannya. Sehingga diperlukan suatu aturan terhadap standar metadata yang sama. Setiap kementerian lembaga yang bertanggung jawab terhadap data di sektornya merupakan wali data dari data di sektornya masing-masing. Bapak dan Ibu sekalian, saat ini Peraturan Presiden tentang Satu Data Indonesia telah dikeluarkan melalui Peraturan Presiden Nomor 39 Tahun 2019 tentang Satu Data Indonesia, yang merupakan acuan pelaksanaan dan pedoman bagi instansi pusat dan instansi daerah dalam rangka penyelenggaraan tata kelola data untuk mendukung perencanaan, pelaksanaan, evaluasi, dan pengendalian pembangunan. Selain itu, pengaturan Satu Data Indonesia juga bertujuan untuk mewujudkan ketersediaan data yang akurat, mutakhir, terpadu, dapat dipertanggungjawabkan serta mudah diakses dan dipakaikan antar instansi pusat dan instansi daerah. Sebagai dasar perencanaan pelaksanaan Satu Data Indonesia, pemerintah mendorong keterbukaan dan transparansi data sehingga tercipta perencanaan dan perumusan kebijakan pembangunan yang berbasis pada data. Bapak dan Ibu yang saya hormati, di sektor kesehatan, pelaksanaan Satu Data ini diwujudkan melalui keleluasaan untuk berbagi pakai data dengan standar dan metadata yang sama yang telah disepakati sebelumnya, termasuk kesepakatan dalam menjaga keamanan data yang ada pada masing-masing pihak, juga data yang dipertukarkan. Data dari sumber yang sama tidak dapat diinput lebih dari sekali untuk aplikasi yang sama. Melalui interoperabilitas, data yang diinput pada suatu aplikasi dapat juga dimanfaatkan oleh aplikasi lainnya yang membutuhkan data yang sama. Hal inilah yang menjadi semangat dalam integrasi sistem untuk mewujudkan Satu Data Kesehatan, juga merupakan kontributor untuk Satu Data Indonesia. Bapak Ibu yang berbahagia, pada era teknologi Indonesia 4.0 ini, Kementerian Kesehatan telah melakukan transformasi kesehatan. Dengan salah satu pilarnya adalah transformasi teknologi kesehatan. Dalam rangka penyusunan transformasi teknologi kesehatan, telah disusun 3 program prioritas. Ketiga program prioritas tersebut adalah: pertama, integrasi dan pengembangan sistem data kesehatan. Yang kedua, pengembangan sistem aplikasi pelayanan kesehatan. Yang ketiga adalah penguatan ekosistem teknologi kesehatan. Konsep Satu Data Kesehatan dapat diwujudkan pada program prioritas yang pertama maupun yang kedua. Sebagai bentuk pelaksanaan satu data Indonesia, Kementerian Kesehatan perlu menyediakan standar untuk interoperabilitas, baik antar sistem lembaga dan kepemerintahan maupun antar sistem layanan kesehatan. World Health Organization atau WHO telah merekomendasikan Health Level 7 Fast Health Interoperability Resource atau HL7 FHIR sebagai standar interoperabilitas. Kementerian Kesehatan mendukung pemanfaatan standar HL7 FHIR ini di Indonesia karena WHO telah merekomendasikan penggunaan itu untuk verifikasi data vaksinasi pada penerbangan internasional antar negara, dan HL FHIR ini telah dipakai oleh berbagai pihak dan berbagai negara di lingkungan internasional. Akan tetapi, kondisi saat ini expert untuk HL FHIR masih terbatas untuk di Indonesia. Bapak, Ibu, dan hadirin yang berbahagia, pada kesempatan webinar dan pelatihan ini, kami mengundang berbagai elemen untuk mempelajari dan memahami FHIR untuk dapat diterapkan sebagai standar interoperabilitas antar sistem layanan kesehatan di Indonesia. Kami mendukung pelatihan yang diprakarsai oleh World Bank ini dan dilakukan dengan melibatkan seluruh unit utama di lingkungan Kementerian Kesehatan, seluruh dinas kesehatan provinsi, kabupaten atau kota, kemudian juga BPJS Kesehatan, rumah sakit vertikal, perwakilan RSUD, rumah sakit swasta jejaring, para pengembang sistem informasi swasta, dan akademisi. Bapak Ibu yang saya banggakan, demikian beberapa hal yang saya sampaikan pada kesempatan yang baik ini. Semoga terlaksananya webinar dan pelatihan ini dapat mendukung upaya pengembangan interoperabilitas antar sistem, khususnya data individual, untuk layanan kesehatan yang ada di Indonesia dengan menggunakan standar WHO yang telah digunakan di kalangan internasional. Dengan hal ini kita dapat mewujudkan satu data kesehatan untuk mendukung masa depan kesehatan Indonesia dan masyarakat Indonesia menjadi lebih baik. Semoga webinar ini benar-benar memberikan manfaat untuk kita semua dan menjadi awal komitmen kita semua mewujudkan satu data kesehatan yang handal dan mampu menjawab tantangan kesehatan di masa yang akan datang. Akhir kata saya ucapkan wassalamualaikum warahmatullahi wabarakatuh. Kepala Pusat Data dan Informasi Kementerian Kesehatan, Dr. Anas Ma'ruf, MKM. Demikian Bapak Ibu sekalian, saya sudah bacakan pembukaan atau opening speech dari Bapak Kepala Pusat dan Data dan Informasi. Waktu dan tempat saya kembalikan kepada pembawa acara. Terima kasih.
Ya, terima kasih banyak Pak Rudi telah menyampaikan pesan dan arahan dari Bapak Kepala Pusdatin. Dan arahan ini nanti akan kita tindak lanjuti melalui acara webinar dan juga melalui acara pelatihan workshop yang nanti akan kita lakukan tidak lama lagi, mulai minggu depan. Baik, mungkin saya bisa sedikit share untuk rencana acara kita untuk kegiatan pelatihan dan juga untuk acara webinar pada pagi hari ini. Jadi berikut ya, Bapak Ibu bisa melihat bahwa hari ini kita akan berdiskusi mengenai kebijakan standar interoperabilitas sistem informasi dan mengenal lebih lanjut apa itu FHIR, apa itu HL7, nanti yang akan dijelaskan oleh expert kita juga. Kemudian tadi sudah ada arahan ya dari Bapak Kepala Pusdatin mengenai rencana kita untuk menggunakan HL7 FHIR sebagai standar interoperabilitas sistem informasi. Dan tentu saja karena expert yang ada untuk penggunaan FHIR di Indonesia itu masih sedikit, jadi kita mengundang Bapak Ibu ya dari instansi pemerintahan maupun swasta untuk nanti kita bisa bergabung untuk melakukan pelatihan workshop bersama selama beberapa kali pertemuan secara serial untuk kita bisa menyelesaikan use case sistem interoperabilitas dengan menggunakan HL7 Fire. Jadi case yang nanti mungkin akan kita gunakan adalah bagaimana kita bisa menyambungkan rekam medis kita yang ada di rumah sakit dengan electronic health record yang ada di Kementerian Kesehatan. Seperti itu yang nanti akan kita coba untuk selesaikan dengan menggunakan HL7 Fire sebagai outcome dari workshop kita bersama. Jadi untuk workshop ini nanti sistemnya akan kita berikan melalui jalur undangan karena mohon maaf kita juga saat ini masih memiliki keterbatasan dalam hal untuk pembicara sehingga untuk masing-masing gelombang kita harus bisa mengakomodir sekitar 50 sampai 60 orang untuk bisa hadir untuk kita nanti bersama-sama secara teknis ya kita menyelesaikan use case tersebut. Kemudian untuk baik maupun gelombang 1 maupun gelombang 2 nanti masing-masing sekitar 60 orang yang nanti akan kita undang untuk bisa hadir di dalam workshop tersebut. Jika nanti masih ada slot untuk atau kapasitas masih ada kapasitas untuk mengikuti pelatihan workshop, mungkin Bapak Ibu bisa mengirimkan kepada ketertarikannya kepada para co-host kepada co-host kami sehingga nanti bisa kami data terlebih dahulu dan nanti akan kami kirimkan undangan jika nanti masih terdapat kapasitas untuk kita bisa melakukan workshop bersama. Seperti itu Bapak Ibu nanti jika ingin mendaftar di dalam workshop ini. Jika dari instansi pemerintahan maka nanti di gelombang 1, jika nanti dari Bapak Ibu dari instansi di luar pemerintahan atau swasta mungkin bisa mendaftar untuk yang gelombang kedua. Baik, seperti itu saja dari saya, tidak ingin berlama-lama, nanti mungkin sembari menunggu pembahasan dari Bapak Setiaji selaku Chief dari Digital Transformation Office, mungkin kita bisa mendengarkan dahulu paparan tentang standar interoperabilitas data dengan menggunakan Fire berdasarkan pengalaman yang pernah dilakukan oleh Dr. Raymond maupun Dr. Philip yang saat ini beliau banyak sekali berkecimpung di dalam interoperability lab di Asia. Baik, kepada maybe for Dr. Raymond or Dr. Phillips, please we welcome you to present your presentations. Thank you very much.
Good morning to all of you. So we would like to extend our congratulations to Pustatil and World Bank for organizing this webinar. I think this webinar series is just a start for Indonesia to gain expertise in HL7 Fire. Definitely, we will not have experts within 4 weeks. So I think the goal of the webinar series is to identify people who can be experts, and then we point you to materials to other experts so that we can create a community of experts for Indonesia. The HL7 Fire is built on the premise of community building. So I think it's very important for us to build that community in Indonesia as well. So for the first topic for today, I will be presenting a discussion on the foundation of interoperable digital health. Basically, we want to set the context for the next series of topics and in this webinar series. So I am Philip Vicensoniga, and with me is Dr. Raymond Harmieto. So we are both from the Standard and Interoperability Asia, and we have organized similar workshops with other countries in the region as well. So we look forward for a very fruitful workshop. So before I start, just a disclaimer, the opinions that I will be expressing are my opinion, and they do not represent the opinion and views of the organization that I represent. Okay. So what will I cover for the next 30 minutes? So before we start our discussion on HL7 Fire, I want to first give an introduction to digital health so that we will have a standard definition so that all of us will have the same terminologies. And then I will be discussing what is interoperability, because interoperability has been a very popular terminology in the world right now. So I would like to define it later. And then finally, I would like to discuss why is interoperability important? Why is it very popular right now? And lastly, I think it will be important for us to know how will the country benefit from interoperability? So this will be our agenda for the next 30 to 40 minutes. So when we say digital health, what does it mean? We have to take note that right now we are actually in the fourth wave of the digital health evolution. Okay, so in the past there were other terminologies that were used. During the 1950s and the 1960s, the term being used is ICT in health. And then from 1960s to 2000, it was health ICT. And then I'm pretty sure that many of us are familiar with the term e-health. So this became popular during 2000 to 2010, 2020. But now, many of the experts are actually using the terminology digital health. So maybe we would like to ask, what are the differences of these terminologies? During the 1950s, when they said ICT in health, it actually refers to the use of billing, accounting systems, logistics systems in hospital facilities. We know that in other industries like business, government, they are already using billing systems, they are already using accounting systems, logistics systems. So during the 1950s, these were the first ICT innovations that were done, that were used in health facilities. So the goal of the first wave is to ensure that health facilities will function well. So the things that work in business, in government, so accounting systems, billing systems, they transferred it to health facilities. Okay, so those were the first systems that were actually computerized. So that is what we call ICT in health, and that was done in the 1950s. As we move along during the 1970s, 1980s, the next things that were computerized are X-ray systems, laboratory systems. Okay, so those were computerized, innovations were placed into those laboratory systems. And the goal for the second wave was to improve healthcare processes. Okay, so again, for the first wave, it was improving the processes for the hospital. For the second wave, it was improving the processes for healthcare. And then as we move to the third wave, so we now move to the e-health wave, the things that were developed are the EMRs, the EHRs, so the electronic medical records, the electronic health records. We will be defining them later. And these are being used to collect patient data. So for the third wave, the focus is now on ensuring that the collection of and the storage of health data is more efficient. Okay, so going back, first wave, we were looking at improving the processes in health facilities. Second wave was improving healthcare. Third wave is improving the way health data is collected and stored. Okay, and now we are now in the fourth wave. So for the fourth wave, we are the the focus now is digital health. So the main goal of the fourth wave is to integrate health systems to provide patient care. So that the term integration of healthcare systems came as part of the digital health, as part of the fourth wave. Okay. At the same time, this is also the era where innovative technologies like AI, big data, blockchain are being used for digital health. Okay, so this is a very exciting period right now in health, in digital health, because we can see that there's a lot of integration, there's a lot of innovation that is actually being done. Okay, so of course we want to focus on integration and interoperability. So to continue, I will be sharing with you a video that we made to explain, because since we are talking about interoperability, we need to clearly understand what we want to connect. So what are the different information systems that are out there? So we know that there are EMRs, there are EHRs, there are HIS, so there are electronic medical records, electronic health records, hospital information systems, what else? We have HMIS, health management information system. So we have those different acronyms, but do we really understand what they mean? So in this short video, we will try to explain the meaning of each of those acronyms. Okay, so I hope you enjoyed this. So this will be very short. I think this is only a 1 minute video. Okay, so I will be playing it. Okay, so going back, so I hope we understood the differences of the four acronyms. So when we say EMR, this is electronic medical record. So this is usually used in one facility only. And then when we say EHR, electronic health record, this is actually a system that is being used in multiple facilities. So it should allow the sharing of data from one facility to another facility. When we say HIS, this is hospital information system. So these are usually the information systems that are being used in hospitals. So they combine the various modules like billing, accounting, logistics, human resources. So usually an HIS will also have an EMR inside. And then when we say HMIS, this basically integrates the data that are being collected from EMR, EHR, HIS so that we can do health analytics, we can do dashboard, those things. So I think the closest example for an HMIS that we should be familiar with is the DHIS2 system. So the DHIS2 system is actually a good example of an HMIS. Okay. However, aside from these things, there are let me stop this. There are other information systems that we have to consider as well. So there are what we call program-based information systems. So these are information systems that have specific functionalities. Okay. So for example, this is very popular right now. A vaccine information system is an example of a program-based system. So of course, we are all familiar. So for a vaccine information system, this is the collection of all vaccine-related data for a particular locality. Aside from that, we also have, I think we are also all familiar with this, a pandemic surveillance system. So a pandemic surveillance system basically monitors how a pandemic is being happens in a country. We also have disease registries. So when we say disease registries, these are databases that contain the various instances of a disease. For example, if there will be a cancer registry and HIV registry, so these are the databases for those diseases. We also have patient registries. So when we say patient registries, these are the list of all patients in the country. Okay. We also have health facility registry. So when we say health facility registry, this is the list of all health facilities in the country. Okay. We also have health worker registry. So when we say health worker registry, this is the list of all health workers in the country. So we have to be conscious that when we talk about digital health information systems, we are not only talking about EMRs or EHRs. We are also talking about patient registry, health facility registry, health worker registry, pandemic surveillance systems, vaccination information systems, and even wearables. So right now, we know that in many mobile phones, in many in many devices, we can actually collect health data as well, and these are part of the whole digital health ecosystems. Okay. So I think the question that we want to answer in general is, how will they all work together? So during the past, I think 10 minutes, I have been mentioning a lot of information systems. But the challenge, I think, that we face right now, so, and this is not only for Indonesia, this is true for every country in the world, even Australia, even the US, they are still trying to grapple on this challenge. How will all those information systems work together to support and to improve patient health care? I would like, so this is a very interesting tweet. Okay. So why is it very hard to share records between doctors when it is actually very easy for us to transfer records when we change our phone? So if you are using an iPhone before and you bought another iPhone of a different version, it's actually very easy to transfer the data from one phone to another. Why can't we do that with health? For another example, why is it easy to withdraw money from anywhere around the world, even if you are using a different bank, even if the ATM that you are, the machine that you are withdrawing to is using a different bank? I was in Jakarta before, And it was actually very easy for me to withdraw money. So why is it easy for the financial sector to do that? And why can't we do that in health? I think that's a very valid challenge. So what was done by those industries that we cannot do in health? Oh, sorry. The answer actually is that the financial industry was one of the first industries that adopted standards and interoperability. MasterCard, Visa, they actually followed the same standard. Okay, so I think the health sector has been a little bit delayed when it comes to using standards and interoperability, mainly because during the early days, doctors, health professionals, they don't see that much value in interoperability before. Okay, so I think one of the positive things that COVID-19 has done is it really emphasized the need for us to have interoperable systems. It was, I think, the message from Anas and was very important. We cannot move forward without having interoperability. Even if COVID-19 is already over, we cannot stop. We cannot reverse the things that we have done. We have to move forward with interoperability. Before we go deeper, I think I want to emphasize first interoperability. I think we need to define it clearly. Interoperability is the capability of software systems to share data with one another. Okay, so I think that is the simplest definition of interoperability that we can provide. This is the capability of software systems to share data with one another. And the concept of interoperability has been there since World War II. So I think that it's about time that this terminology is also adopted for health. We have been celebrating interoperability. We have been discussing interoperability for the longest time. However, there have been challenges that have been encountered. So what are the challenges that are being encountered? So why is it not very easy for us to be interoperable? The biggest challenges that we have seen for that prevents countries from being interoperable are, number one, vendor lock-in. So vendor lock-in is a challenge because the tendency of vendors is that when you use a particular system, you should also use the other systems from that vendor. Okay, so that have prevented other systems to connect with that. Because of course, if I am a vendor, I want you to use not only system A, but I want you to use system B, C, D, E as well. So I want to prevent you from using other systems if I want you to buy my system. So that is for us one of the biggest challenge for interoperability. The second one is for health facilities, especially for hospitals, there's always a tendency to focus on billing systems. Well, it is understandable because billing systems are the ones that we use to monitor the revenue. Okay. So that is a challenge that we have seen. Number three is usability. So there's more usability for systems. So if I cannot use this system well, how can I make it interoperable with other systems? Number four, systems are developed by different people. So we have seen information systems that have been developed by different developers and that have presented a challenge because it is very hard to connect systems that are developed by others. Okay? So that is another challenge that we have seen. Another thing is security. Of course, if we increase interoperability, if we allow other systems to access our data, that will increase our security risk. Okay, so that's another challenge as well. Next is the workforce for digital maturity is low. This is two ways. Number one, there are not enough experts. As mentioned by Iyo earlier, the expertise on fire for Indonesia is quite low yet. So it's a challenge for us to adopt interoperable solutions if the maturity, if the number of people who are capable is low. Next is professional standards are not met. And finally, governance policies is weak. So later on, I will discuss what we need to do to be interoperable. And one of the challenges that we have seen is that there's lack of governance in some aspects. So I want to emphasize that even if we have an electronic health record system, it does not mean that we have a health information exchange. And I will be explaining later what a health information exchange is. So without an HIE, without interoperability, it's virtually impossible to derive benefits because we know that in general that patients usually transfer to different health facilities. It is very seldom that we will see a person who will stay on the single health facility for the rest of his life. It's not happening. Okay? So they are changing their position. And I think it is important for them to bring the record that they have. And that is what interoperability, that is what an HIE brings. This is an interesting article. So since we are talking about COVID-19 earlier, I saw this article in a US journal, and this was written in 2020. Actually, this was written almost a year ago. Interoperability was seen as an tool in America's fight against COVID-19 because even in the US, they are also having challenges in interoperability. So they were not able to maximize their own infrastructure because some of those are not interoperable. Okay. So I think for COVID-19, this is very, very essential. We need to have interoperable systems for us to improve our battle against COVID-19. And I think Indonesia has been doing that. I think Indonesia, at least for the COVID-19 part, we have been trying to connect. We have connected laboratories, we have connected health facilities, and that is good. However, next year or maybe 2 years from now, COVID-19 will be controlled. The more vaccinated people that there are, the more the higher the probability that we can control COVID-19. And after we have controlled COVID-19, we will go back to our original problem, which is universal health coverage. Okay? And hopefully, I think to end my message now, hopefully by the time we control, by the time we win over COVID-19, by the time we go back to the period of UHC, we should have an infrastructure that is ready already that can support that. Okay, so we hope that we should be able to continue the work that we have done for COVID-19, and we will be able to bring them as we face UHC, because I think UHC is a far bigger challenge than COVID-19. With that, I think I will stop right now. I will open the floor for questions. Pak Iyo, are there any questions?
Yeah. Ya, thank you very much, Dr. Phillips. Terima kasih banyak kepada Bapak Setiaji yang telah bergabung bersama kami pada pagi hari ini. Selamat pagi, Bapak Setiaji.
Selamat pagi.
Ya, baik Pak Setiaji, terima kasih banyak Pak. Ya, mohon izin Bapak, apakah Bapak memiliki tanggapan tentang paparan yang disampaikan sebelumnya dari Dr. Philip terkait dengan sistem interoperabilitas data yang saat ini penting sekali untuk dilakukan di dunia, Pak, seperti itu. Dan apakah itu bisa kita terapkan di Indonesia? Mungkin mohon tanggapannya, Bapak.
Ya, pertama-tama selamat pagi semuanya buat Bapak-Bapak dan Ibu sekalian. Sangat senang sekali ya, very happy to join this session. Dan kemudian terima kasih buat Mr. Phillips ya, yang telah menyampaikan bagaimana pentingnya FIRE ya untuk melakukan integrasi terhadap sistem layanan kesehatan. Nah, mungkin saya cerita. Saya boleh share nggak slide ya untuk menanggapi?
Ya, silakan Pak. Silakan.
Ya.
Bisa.
Ya, sorry in bahasa ya.
Nggak bisa Pak. Kita ada fitur interpretasi untuk bahasa Inggris dan Indonesia,
ya.
Pak.
Jadi saat ini Kementerian Kesehatan sedang melakukan transformasi digital ya untuk mulai melakukan digitalisasi kesehatan dari mulai kandungan hingga sampai dengan krisis ya. Yang ini nanti akan berbasis data individu. Nah, untuk kepentingan ini pastikan ada berbagai macam lab, berbagai macam rumah sakit, kemudian berbagai macam peralatan device ya, wearable device yang harus kita konekkan. Tentunya tidak akan mudah bagi kita untuk melakukan interoperability tadi kalau kita tidak memiliki standar untuk interoperability sebagaimana tadi disampaikan oleh Mr. Phillips ya. Nah, kami sudah mencoba melakukan analisis dan melakukan uji coba integrasi dengan model-model integrasi yang standar gitu ya. Dan tentunya itu untuk mengatasi berbagai macam isu. Kita ketahui bersama data itu sangat terfragmentasi, jadi kurang lebih ada 400 aplikasi sistem di Kementerian Kesehatan, yang itu sangat luar biasa. Jadi kalau kita lihat di puskesmas ada kurang lebih 70 aplikasi, kemudian di hospital, rumah sakit itu kurang lebih ada 50 aplikasi, dan belum lagi aplikasi-aplikasi lain di layanan klinik dan sebagainya. Nah, oleh karena itu, interoperability ini, standarisasi dan lain sebagainya sangat penting untuk kita bisa mulai dilakukan di Indonesia. Ya memang kita baru start ya, bagaimana melakukan standarisasi dan kemudian melakukan berbagai macam inisiasi digitalisasi. Nah, salah satunya adalah bagaimana kita bisa mengintegrasikan data kesehatan berbasis elektronik medical health records yang untuk mengintegrasikan aplikasi-aplikasi layanan kesehatan yang ada. Jadi kami punya pengalaman bagaimana mengintegrasikan sistem penanganan COVID ini ya, tapi sayangnya memang belum berbasis standarisasi seperti SL7 dan kemudian FIRE ya. Oleh karena itu penting kita mengintegrasikan tersebut. Ini sudah ada platform yang peduli lindungi untuk testing, tracing, ya, dan kemudian membantu untuk melakukan screening. Kurang lebih usernya itu sudah 70 juta. Dan kemudian daily active user itu hingga sampai dengan 9 juta sampai dengan 10 juta. Kita sudah punya platform yang cukup bagus, tetapi problemnya adalah interoperability-nya. Bagaimana ini nanti connect dengan lab, terus kemudian connect dengan hospital, ya, dan kemudian dengan connect juga dengan platform digital lain seperti telemedicine. Kurang lebih sudah 11 platform telemedicine yang sudah terintegrasi dengan kami, termasuk juga dengan platform non-kesehatan, ya seperti Gojek, Grab, tiket Traveloka dan lain sebagainya, dan many others platform yang akan kita integrasikan dengan sistem kesehatan kita. Nah, ini yang perlu kita lakukan adalah bagaimana menginteroperabilitikan ya berbasis electronic medical record, sehingga kita akan punya 2 aplikasi besar yang untuk patient ya, facing application, dan kemudian juga untuk health workers, tenaga medisnya, yang harus untuk bisa melakukan services, berbagai macam services. Kami mencatat kurang lebih di UK itu 40 lebih services ya, bagaimana untuk connect dengan sistem yang lain, termasuk juga dengan dokter keluarga ya, practitioners, terus kemudian juga dengan wearable device dan sebagainya. Nah, inilah yang kita perlukan untuk membangun sebuah interoperability yang baik, sehingga pada waktu kita mengkonekkan sistem dan yang lainnya sebagainya bisa membantu kita mempermudah. Karena kurang lebih kami mencatat 60.000 health facility, baik dari tingkat primary, sekunder, maupun juga yang klinik, ya, lab, apotik, itu yang harus kita integrasikan. Oleh karena itu penting bagi kita untuk melakukan standarisasi, ya, electronic medical record, dan kemudian ada data exchange-nya menggunakan FHIR, sehingga ini akan memudahkan kami untuk mengintegrasikan seluruh fasilitas kesehatan yang tadi saya sebutkan. Dan untuk tahap pertama, kita akan menginteroperabilitikan BPJS ya, untuk jaminan kesehatan nasionalnya, dan kemudian nanti terus kita kembangkan untuk mengintegrasikan dengan layanan-layanan kesehatan lainnya. Ya, kita sudah punya beberapa agenda untuk melakukan ini. Mudah-mudahan dengan tema diskusi pada hari ini dan kemudian dibantu nanti juga oleh World Bank, termasuk para expert, kita ingin pertama adalah bagaimana memulai melakukan ini ya. Bagaimana kita start dengan kondisi legacy system, terus kemudian bagaimana kita start dengan existing system yang sudah cukup banyak, dan kemudian bagaimana nanti juga memfasilitasi sistem-sistem yang lain yang tidak dimiliki oleh rumah sakit. Kurang lebih kita mempunyai data 60% sistem di rumah sakit itu sudah memiliki electronic medical record, tetapi the rest sisanya belum lagi puskesmas, masih banyak ribuan yang belum memiliki sistem ini. Oleh karena itu penting dan sepertinya ini langkah bagus untuk kita melakukan interoperability, mulai melakukan standarisasi dan sebagainya agar personal health record kita bisa terwujud. Ya, saya rasa itu tanggapan kita, jadi sangat penting sekali untuk melakukan standarisasi dan interoperability sebagaimana yang disampaikan oleh Mr. Philip tadi.
Baik, terima kasih banyak untuk paparannya, Pak Setiaji, sangat bermanfaat sekali. Mungkin dari Pak Philip bisa menanggapi tentang rencana dari Indonesia untuk bagaimana menggunakan HL7 Fire ini untuk mengintegrasikan berbagai aplikasi yang saat ini dimiliki. Jadi tadi di jumlah aplikasinya lebih dari 100 ya Pak ya, yang kita miliki ya Pak ya. Dan itu bagaimana nanti pelan-pelan nanti kita akan integrasikan satu sama lain. Dan untuk saat ini untuk sistem pada COVID-19 itu sudah terintegrasi satu sama lain, tetapi masih belum menggunakan, prosesnya tersebut masih belum menggunakan standar HL7 Fire ya Pak.
Betul.
Ya, baik. Ya, mungkin Pak Philip bisa menanggapi. Please have your comment about the plan of Health from Indonesia.
Actually, I was very impressed with the presentation earlier because I think it's very clear that we will be using FHIR for Indonesia. Next week, we will be discussing different architectures on how FHIR can be used. And I think one of the exercises that we can do is we can do a brainstorming, because we already see a diagram. Basically, that's the architecture already. But I think what's important for us is to identify which area will benefit with the use of FHIR. In the diagram shown earlier, we saw that there's a connection using HL7 version 2. There's a connection that's using HL7 FHIR, and that's very good because we are aware that we don't need to use fire in every connection. We need to identify the connections that will benefit most. Okay. Again, in the discussions that we will be doing for the next 4 days, I think the main message is fire is not the solution to everything. There will be some use cases that will benefit, and then there will be some use cases which will not benefit that much. So I think we should be able to use the next 4 days, the next 4 webinars to identify which areas of the whole ecosystem will benefit with the fire standard. So yeah, I think that's all from me.
Ya, ya, thank you Pak Philips. Ya, mungkin Pak Setiaji bisa menambahkan pertanyaan dari Pak Philip tadi tentang penggunaan fire tersebut, Pak.
Ya, thank you Mr. Philips ya for your comment dan juga masukannya juga. Ya, tentunya kita akan melanjutkan diskusi ini dengan bahasan-bahasan yang non-technical ya, karena Mr. Philip kan sudah memiliki experience bagaimana memulai penggunaan ini dan kemudian memilih mana yang harus didahului gitu, karena tidak mungkin kita langsung seluruhnya, tetapi kita mulai dari sektor yang mana dulu gitu ya, tadi sebagaimana disampaikan oleh Mr. Philips, dan kemudian nanti ada tahapan gitu. Nah, akan sangat senang sekali mungkin kita juga bisa mendapatkan journey untuk pemanfaatan fire ini ya, steppingnya seperti apa, terus kemudian kita mulai dari yang mana, kemudian full package-nya nanti seperti apa gitu. Dan tentunya juga berharap terhadap apa yang harus kita, teknologi mana yang kita gunakan, karena banyak sekali sekarang teknologi fire ini yang ditawarkan ke kami gitu ya. Karena kami memiliki 270 juta jiwa penduduk, sangat besar. Kita negara keempat terbesar di dunia. Oleh karena itu kita harus memikirkan secara teknologi yang bisa mengcover 270 juta penduduk Indonesia ya. Nah, itu tentunya butuh masukan yang lebih detail nanti dari Mr. Philips. Thank you.
Ya, baik. Ya, ya terima kasih banyak Pak Setiaji. I think Mr. Philips already agree with the statement from Pak Setiaji. Okay, thank you very much Pak Philips. And after this, setelah ini kita akan masuk ke dalam sesi pertanyaan tanya jawab ya, mungkin sekitar 15 menit. Tadi ada pertanyaan dari Pak Guardian yang menanyakan bahwa saat ini memang proses interoperabilitas itu memerlukan sebuah kebijakan yang selalu berkelanjutan, Pak Setiaji. Nah, apa saja strategi dari Kementerian Kesehatan untuk menjamin bahwa adanya keberlangsungan dari inisiasi yang kita lakukan saat ini, Pak? Jadi jangan sampai kita sudah berlanjut nih, kemudian nanti di tahun mungkin ya nanti ada perubahan kebijakan ke depannya. Kira-kira seperti apa, Pak?
Ya, yang pasti kita akan mengamankan ya dengan berbagai regulasi. Pertama, standarisasi. Jadi bulan ini kita akan meluncurkan electronic medical record standar ya, yang harus diacu oleh seluruh fasilitas kesehatan. Dan kemudian nanti kita juga akan hubungkan dengan insentif dan disinsentif agar ini bisa diadop oleh rumah sakit ataupun vaskes. Nah, yang kedua, kita juga akan fasilitasi sistem ya, apabila rumah vaskes khususnya puskesmas ya di primary care itu tidak memiliki sistem. Jadi kita akan menyiapkan minimum sistem ya untuk servicesnya tadi, sehingga seluruh rumah sakit terus juga fasilitas primer memiliki electronic medical record. Nah, kemudian yang berikutnya lagi kita juga akan memperbaiki referensi ya, kode referensi terhadap untuk mendukung ya sistem ini interoperability-nya. Dan kemudian jangan khawatir, kita kan saat ini di Kemenkes sudah men-setup tim yaitu Digital Transformation Office yang istilahnya adalah startup tetapi bekerja di pemerintahan ataupun GovTech-nya. Ini yang nanti dalam rangka untuk menjamin sustainability-nya. Kemudian tentunya juga menggalang ekosistem kolaborasi dengan tahun ini kita akan meluncurkan health tech space di mana di dalamnya ada ekosistem kolaborasi dengan berbagai macam ekosistem kesehatan untuk sama-sama align dengan program kita. Karena selama ini kan ada asosiasi A, B, C, D, jalan dengan sendiri-sendiri. Itu yang akan kita engage ya, sehingga ini tentunya akan berkelanjutan. Kemudian yang berikutnya lagi, karena ini sudah ditanamkan secara fondasinya, harusnya sih bisa lebih sustain karena masyarakat membutuhkan hal tersebut gitu ya. Terima kasih.
Baik, terima kasih Pak Setiaji. Jadi memang tadi ada inisiatif dari Kementerian Kesehatan untuk meluncing electronic health record ya, di mana nanti akan ada insentif jika nanti dari rumah sakit bisa memasukkan untuk data-data tersebut untuk bisa terkoneksi dengan IHR tersebut. Baik. Kemudian maybe questions from for Dr. Phillips. Hi, hello, Dr. Phillips. Yeah, I have a questions about regarding the training that we will conduct maybe in the next few weeks. Whether is it possible for us to have the at least an expert in fire utilizations in Indonesia?
Sorry, can you repeat the question?
Yeah, okay. Yeah, maybe for Dr. Phillips, whether our training that we will conduct in the next few weeks, it's able to have the experts that able to perform, to use the fire in Indonesia. And what is the next step after the training?
Yeah, for the next training, as I mentioned earlier, we will try to provide the foundation, the fundamentals that will be enough for Indonesia to use fire already. However, when we say expert, it requires certification, it requires higher degree. The HL7 community has the certification exams. So although we can provide the material, we can provide the discussion, the certification exam can only be given by the HL7 organization. So, but definitely after our workshop, we should have enough capacity already to implement fire.
Yeah. Okay. Yeah, we hope we have the capacity to implement fire in a short time so we can begin the interoperability process. Yeah. Oke. Terdapat pertanyaan berikutnya untuk Pak Setiaji dari Pak Windiarto. Mungkin saya bisa bacakan Pak Setiaji. Jadi ada pertanyaan, kenapa tidak dibuatkan saja standar seperti yang dilakukan oleh BPJS Kesehatan dalam mengelola mobile JKN? Jika data tetap di rumah sakit masing-masing dan BPJS menyediakan middleware untuk query ke rumah sakit. Dengan cara seperti ini, data tidak akan menjadi duplikasi dan bisa diakses secara real time dari rumah sakit tanpa harus masuk ke server Kemenkes. Mungkin bisa mengklarifikasi Pak Setiaji.
Ya, jadi pertama gini, bahwa BPJS itu pertama belum menggunakan standar yang FIRE ya, SL7. Dan kemudian yang diambil oleh BPJS itu bukan data detail, tetapi data tindakan berdasarkan INASIBGIS-nya. Jadi kita tidak mengetahui detail obatnya apa yang digunakan, terus kemudian karena sifatnya hanya diagnosis. Nah, oleh karena itu kita butuhkan data yang lebih detail tadi untuk memastikan obat, terus kemudian memastikan kesehatan, treatment dan sebagainya. Nah, kemudian modelnya itu sebenarnya kita tidak nge-pull datanya. Data itu tetap ada di rumah sakit, federated lah istilahnya, tetapi rumah sakit wajib untuk bisa diakses oleh Kementerian Kesehatan maupun juga vaskes yang lain. Ya, jadi ini dalam rangka untuk mendukung personal medical record. Jadi kita akan memiliki sebuah aplikasi di mana kita dari mulai lahir hingga sampai dengan dewasa dan sebagainya punya catatan medis yang kita bawa. Nah, itu yang biasa juga common dilakukan di beberapa negara, dengan konsen tertentu sehingga vaskes-vaskes tadi bisa mendapatkan data-data medical record, terutama resumnya untuk layanan tadi. Nah, itulah. Jadi kita juga akan melakukan standarisasi terhadap BPJS juga untuk bisa menggunakan FHIR ini. Kurang lebih begitu.
Baik, jadi data itu tidak di-pool ya Pak ya, tetapi
Ya,
data tetap ada di rumah sakit.
Betul.
Apakah nanti pengisiannya akan menjadi duplikasi Pak antara yang aplikasi dimiliki rekam medis rumah sakit dengan nanti data yang harus dikirimkan ke RS itu, apakah akan menjadi duplikasi Pak atau membebani tenaga kesehatan untuk mengisinya? Bagaimana?
Tidak, justru ini karena kan sebagian besar ternyata aplikasi dari Kemenkes itu melakukan pencatatan yang double ya. Justru dengan kita langsung menarik dari medical record layanan rumah sakit tadi, itu tidak akan duplikasi. Nah itu justru itu, jadi tidak ada lagi inputan yang sama, istilahnya single form. Nah ini pasti akan mengurangi beban para nakes tadi. Mereka concern hanya untuk sekali input, kemudian itu akan dikonsumsi juga oleh Kementerian Kesehatan, khususnya untuk kita sebut summary medical record-nya.
Baik, ya. Inisiatif yang sangat menarik sekali Pak. Baik, nanti kita berharap pelaksanaan juga nanti akan menjadi lebih lancar. Baik, mungkin ada pertanyaan, mungkin 2 pertanyaan lagi ya, karena waktu juga yang terbatas. Jadi ada, we have a questions for Dr. Phillips. From Pak Guardian also, the question is, does Philippines adopt the FHIRs for the nationwide in Philippines? And in the presentation, it is also mentions about the facility registry, health worker registry, and also does Philippines adopt the clinical terminology and drug terminology standard? Yeah, please Pak Philip.
For the short answer, yes, the Philippines have a resolution, a policy from the Department of Health, from our Ministry of Health, that the FHIR standard will be used for health data exchange. Actually, for COVID-19, our national surveillance system for COVID-19, it uses FHIR, and it requires the different systems who want to connect to it also use FHIR. I think Dr. Raymond, since he is from the e-health working group, he can expound more on the different policies that from the Philippines. Dr. Raymond. Yeah.
Yes, for the Philippines, there have been administrative orders set out by our Ministry of Health, and also that's in coordination with our Philippine Health Insurance Corporation, which is, I think it's BPJS if I'm not mistaken, for the counterpart for Indonesia. The reason for that is because we are trying to build a critical mass in terms of the number of people who are competent and skilled enough on HL7 FHIR, so that there will be a base of a stable human resources who are capable of implementing HL7 FHIR in the Philippines. That's number 1. Number 2, our Philippine Health Insurance Corporation will also be requiring that of all electronic medical records and health records. And that is the only, that the direction right now is that should that be put in place, that will be the only way that the health facilities could receive the reimbursements from the National Health Insurance Program. We are all, for the terminology question, we also have the Philippine National Drug Formulary, and we have been looking into establishing a national health data terminology service, and we are just waiting for SNOMED to be procured, at least for the Philippines, so that's something that we could incorporate as part of our clinical, our set of clinical terminologies. Thank you.
Yeah, thank you, Dr. Raymond. So in Philippines, you have also an incentive for the hospitals to use the electronic health records. So by using sending the data to the electronic health records, the hospital can claim for the insurance, for the national health insurance,
That's
right?
correct. That is correct.
Okay. Yeah, so it's almost almost the initiative, the same initiative from. Yeah, okay. And maybe the last questions. Mungkin pertanyaan terakhir untuk Pak Setiaji. Jadi ada pertanyaan dari Bu Eni Rahmani, apakah FHIR dijadikan standar untuk interoperabilitas di Indonesia? Seperti itu, Pak. Apakah kita nanti akan selalu stick terhadap FHIR atau menggunakan yang lain?
Ya, kami sih melihat bahwa ini standar yang saat ini yang mumpuni lah, dan juga dipakai oleh berbagai negara. Selain tentunya standarisasi dari, jadi kan FHIR ini juga terstandar juga dengan menggunakan SL7 ya, SL7, terus kemudian data exchange-nya menggunakan FHIR. Jadi saya rasa daripada kita riset lagi gitu ya, sudah ada best practice-nya, kenapa tidak kita menggunakan ini gitu.
Ya, baik Pak. Ya, terima kasih banyak untuk jawabannya. Jadi kalau tidak salah di tahun 2019 lalu dari Pusdatin, dari Kementerian Kesehatan itu sudah belajar banyak ya Pak tentang FHIR dan sudah melakukan instalasi server FHIR juga. Yang inisiatifnya dimulai di tahun 2020, tetapi ternyata ada pandemi ya Pak ya, sehingga kita resource banyak yang terpakai untuk penanganan pandemi, dan saat ini sudah kita berhasil kendalikan dengan cukup baik dengan berbagai sistem informasi yang ada, sehingga inisiatif ini kita kerjakan kembali ya Pak ya. Baik, seperti itu ya Pak ya.
Betul sekali.
Ya, baik, mungkin sebelum kita menuju ke sesi berikutnya, mungkin dari Pak Pandu, apakah ada yang ingin ditambahkan Pak Pandu? Silakan Bapak.
Tidak ada Pak Mas Tio. Terima kasih banyak Pak Setiaji atas kehadirannya dan atas tanggapan dan update mengenai rencana Kemenkes untuk transformasi digital. Terima kasih sekali lagi.
Ya,
baik.
Terima kasih banyak Pak Setiaji. Baik, setelah ini Pak Pandu juga, setelah ini kita akan masuk ke dalam sesi berikutnya. Jadi pada Bapak Ibu yang nanti ingin mengikuti workshop di dalam untuk pelatihan FHIR yang akan kita mulai pada minggu depan, nanti kita akan kirimkan linknya ke dalam kolom chat, nanti bisa diisi, dan nanti kita akan kirimkan undangan kepada Bapak Ibu untuk bisa hadir di dalam pelatihan tersebut. Namun mohon maaf karena kapasitas di dalam pelatihan terbatas, jadi nanti Bapak Ibu yang mendaftar nanti kita akan baca terlebih dahulu, kemudian nanti kita akan lihat dengan kapasitas yang ada, dan nanti kita akan kirimkan undangan bagi Bapak Ibu. Ya, terima kasih banyak. Nanti untuk link pendaftarannya nanti kita kirimkan melalui kolom chat. Baik. Ya, setelah ini kita akan masuk ke dalam diskusi berikutnya bersama dengan Dr. Raymond Francis Sarmiento. Beliau merupakan wakil dari Kementerian Kesehatan dari Filipina sebagai Director of National Telehealth System. Baik, kepada rekan saya Pak Aldilas, saya persilahkan untuk memandu jalannya acara. Silakan Pak Aldilas.
Ya, terima kasih Dr. Tio atas waktunya. Terima kasih Pak Setiaji sudah hadir. Ya, kita akan lanjut ke sesi berikutnya. Jadi kita akan bahas lebih dalam. Jika di awal kita banyak diskusi tentang policy, tentang kebijakan, dan juga mengenai bagaimana dasar-dasar dari interoperabilitas itu sendiri. Kemudian kita akan masuk lebih dalam untuk mengenal lebih jauh tentang HL7 dan juga FHIR. Jadi kalau bisa saya beri gambaran adalah HL7 adalah suatu organisasi non-profit yang memang membuat standar interoperabilitas untuk sistem informasi kesehatan, dan itu sebelum menjadi FHIR memang ada banyak perjalanan dari versi 1, versi 2 hingga di versi sekarang ini menggunakan API menjadi FHIR. Nah, Untuk itu kita akan mengundang Dr. Raymond Francis untuk memberikan paparannya mengenai organisasi HL7 itu sendiri sebelum kita nanti jauh berdiskusi mengenai FIRE. Okay, for Dr. Raymond Francis, the time is yours to show your presentation.
Thank you, Pak Aldelas. I'm going to share my screen. I hope you're able to see my screen as I move on to presentation view.
Yes, I can see. You can see your screen.
Thank you so much. I will be talking in this part of the session for our workshop for today. After Dr. Philip Zuniga had already given an overview on the introduction to standards and interoperability, my talk will be focusing more on HL7. Wow, and how it enables interoperability of health information systems. As you know, we are from the Standards and Interoperability Lab Asia, and we hope this is something that will be useful for all of the attendees that we have right now. Currently, we are almost 200. We hope there are more who will be able to join us, and we look forward to the next weekends that we will be spending time with each other so that we'll know more about HL7 and particularly FIRE. I am just a general disclaimer that all statements issued are mine alone, and my presentation does not necessarily reflect the position of the Philippine government or any of my other affiliations. I also declare no conflicts of interest with any proprietary entities I may mention, and no financial relationships or with the manufacturers of any commercial products or services I may mention. These are my competing interests for this presentation. Learning objectives. By the end of this presentation, the attendee should be able to, number 1, describe what HL7 is and its limitations. Number 2, describe the timeline of events on health information exchange, standards adoption and use. Number 3, explain the importance of using a standard to facilitate health information exchange. Number 4, define, select HL7 terms, how the rules govern how the messages are sent out and exchanged. What are common messages being exchanged between different healthcare facilities, and the data types. And then finally, provide a description, be able to describe what happens given an HL7 message syntax and its content. So I will be, at the end of the presentation, just be giving standard HL7 message syntax, not necessarily for FIRE, but that this is something that for the last decade and a half, maybe even 2 decades or 20 years, is something that has been used globally for most healthcare facilities. HL7 International was founded in 1987. It is an ANSI-accredited standards developing organization, and it's the global authority on standards for interoperability of health information technologies, and deeply involved in worldwide efforts to improve healthcare through information technology. It is also the founding member of the Joint Initiative Council, which is an international council on global health informatics standardization, committed to developing a single standard for a single purpose. It also has an agreement with the International Organization of Standardization, through which HL7 submits its ANSI-approved or draft standards for trial use. Standards directly to the International Organization of Standardization, or ISO, for approval. However, this does not mean that when you use HL7, it is the one-stop shop solution or the end-all for all of your problems when it comes to health information exchange. The list below is some of the functionalities not provided or supported explicitly just because HL7 provides that responsibility and affords that to the healthcare practitioner and or facility. Number 1, on security and access control. HL7 specifically does not provide for a requirement for the enforcement of a user's security policy. It does not specify a specific encryption method, although in principle it espouses security and access control. There are no specific requirements for it to be made to be made as a rule. Number 2, privacy and confidentiality. HL7 does not explicitly address this issue and does not assume how the data will be used at the source or destination of the message, meaning how the data will be exchanged from one facility to another facility. There are no assumptions as to how the privacy and confidentiality will be preserved. Number 3 is on accountability and audit trails. It does not attempt to define possible transaction processing features needed in a user's environment. Although it provides a way for the messages to be audited, there's no explicit requirement for that to be done. In the health standards space, HL7 has figured prominently in terms of its implementation all the way from almost 40 years ago in the 1980s. HL7 version 2, which is what my example will be later on, was the dominant health information exchange standard of the day. In the 1990s, the reference information model and version HL7 version 3 were mentioned and put into place in order to provide some sort of an comprehensive upgrade, if you will, to HL7 version 2. CDA stands for Clinical Document Architecture, which was started in the 2000s, and this is also with the X document sharing file standard that was available during that time. And then in the early 2010s, which is in 2012, UpFire was first introduced, and it's now emerged as potentially the number 1 health information exchange standard for the globe. For health architecture models, we are looking at multiple examples here. Number 1 will be for document exchange, how they do it in the United States of America. There is really a health information exchange set up at the middle, which allows an electronic medical record from one facility to exchange that data to another electronic medical record, and so on and so forth. Canada, on the other hand, employs a much more centralized approach using the central repository. All of the electronic medical records are required to submit all of their data to a central database, and therefore, if they have to pull any information from the central database, let's say a patient that's seen using this EMR, we need to be seen using this EMR, they will have to go through the central database. And then finally, the app model. The app model is what the Smart on Fire apps have been using. If you are familiar with the smart health cards or the digital vaccination health cards that's built on Smart on Fire, that is an example for this application model. What it does is that it passes through a data services layer, so that all of the data coming in from let's say disparate sources of data, which means different and siloed sources of data, they will have to go through this data services layer so that it will be accessed via the apps and portals model. For document exchange, it focuses primarily on pushing documents from one provider to another. The discharge summary, the continuity of care document, the clinical notes and letters and reports, those are the ones being pushed from one health information system to another. This is also what you see here in this diagram. Very widely implemented in the United States, but has limited practical workflows. If you have to refer one patient to multiple healthcare facilities, that will be very, very difficult. The dominant standards for this one are the clinical document architecture and the SOAP for document exchange. Number two, the central repository model, which focuses on building a repository that sits between the systems. It is based on national or jurisdictional policies and guidelines, or if you are within an organization, the organization governs the governance for that. The repository collects all of the data as it is produced and makes it available on demand to anybody who will be pulling data or will be requesting to pull data from it. It has very big and wide implementations in Canada, Europe, and Australia. The dominant standards are IHE X document sharing, HL7 version 2 and version 3 as a example for repository model. For the app model, they are popular anywhere else in the world. They have now slowly infiltrated the healthcare sector and will potentially could be the emerging standard in terms of interoperability model for different countries. The domain standards are custom APIs or an open mHealth. Its purpose is typically built with a narrow focus. So for example, the one that I mentioned on smart health cards or digital vaccination health cards, that's only for vaccination. You cannot use that for anything else. So I think there are practical uses that it could be expanded to, and for which patients and providers could benefit. But the narrow focus is not without its advantages. It reduces the barriers to entry in terms of being able to develop an interoperable application that could be with the data being easily understandable by other providers and the patients. The challenges right now for interoperability are four. Number one, on data models. Number two, on data transport. Number three, on security. And number four, on workflow. So for number one, the existing data models that we have right now are either too basic. That means a lot of countries, their ministries of health, are still lacking in terms of the governance aspect, and they are, let's say, satisfied with just using a basic portable document format or PDF for sensitive information that's contained in electronic medical records. It could even be, on the other end of the spectrum, it could even be too complicated, such as for clinical document architecture. There has to be a sweet spot in the middle wherein we could leverage how easy it is to implement, but also not easy enough that anybody can just replicate it without certain provisions, particularly on security and privacy. For data transport, there are different dominant standards for every purpose. So either you're submitting it via XML, or maybe sending it via CSV. If a particular country is satisfied with already setting up a secure FTP server or SFTP, that could be their dominant standard. It really is very much dependent on the practices for that particular country. For security, it's often an afterthought and often only at the system level. It has to be, so not just at the application level, you have to look into at the data level in itself, at the database. There are also other security measures from an organizational standpoint that you could implement in order to make sure that security is of prime importance. And then workflow. Obviously, humans are very complicated. There's no particular standard workflow when you go from one healthcare facility to another within the country, much less if you go to a different country. It's very, very much dependent on the customs and the practices for that particular country. So the definitions, I have selected a few, and these are HL7, which is an application protocol for electronic data exchange in healthcare environments. When you talk about data types, it's a restriction on the contents of a field, and the field is a string of characters defined by one of the HL7 data types. There's the field separator. This character separates two adjacent data fields within an HL7 segment, and the entire message, which is the atomic unit of data transferred between systems consisting of segments in a defined sequence. Later on, I will be giving an example so that you could much more easily appreciate what I'm talking about here. The second slide shows the message type, which is for the specific purpose. The order, which is a request for material or service. An observation, which is the performance of the service including result data. The segment, the logical grouping of data fields identified by three-letter identification. It could be the MSH header, PID, patient ID header, OBX, observation header. The most important term that is defined in this slide is the last one, which is the trigger event. Because that's everything really depends on the trigger event. It's a real world event, what is happening in the real world. That is the reason that a message is being sent out and there's an exchange of messages. There is really a one-to-many, so there are multiple ways to do this. It could be one-to-one, many-to-one, but for this one, for trigger event, there is a one-to-many relationship between the message type and the trigger event. So for the rules, please remember that the MSH or the message header segment is required and is always the first one to appear if you have an HL7 message. There may be more than one type of segment and it can be nested, which I will show in my example later on. If you see this symbol, this means it's an optional segment, and this one is a repeating segment. For optionality, it could be required, so that it could be a required segment, but it may have an empty value. It could be optional. It could also not be used with the trigger event. C means conditional depending on trigger event or some other field. And B is backwards compatible with previous HL7 versions. So there are HL7 version 2.9, 2.7, 2.5, 2.3, 2.1, etc. that could make that segment be backwards compatible with that. So you will oftentimes, based on practice, what I'm seeing is the R as required, O as optional, and the RE required but may be empty, and the C, the conditional depending on trigger event or some other field. The recommended message delimiters field, which is the field 2 for the MSH segment, are the following. For field separator, we will see a vertical bar that separates the different fields. There's the component separator within that field, which is delineated by a caret symbol. The subcomponent separator, which is the ampersand symbol. The repetition separator, which is this symbol. And the escape character, which is a backslash. So there is a one-to-many relationship. Again, I just wanted to reiterate, for the trigger event, there is a one-to-many relationship between the message type and the trigger event. So ADTs admit, discharge, and transfer with many different events triggering why a patient is being admitted. Trigger events, for the most part, are specific to message type. So, for the rules, there are acknowledgement messages that are sent out to indicate if the receiving application was able to, number 1, parse the message, number 2, decode the message, number 3, if they should be assuming responsibility for the message, number 4, processing the message contents, and number 5, successfully committing it to storage. So those are really how you would be performing it if you were to do it face to face and not be dependent on the computer. So null versus empty. Null is used when data is present but without a value. So the field is left blank when there is no data. So this is an example. This is an example of that one for that particular rule. Number 2 on receiving systems. The receiving systems will ignore the data within segments, fields that are present but not expected. It will also treat expected segments that are not present as a segment with all fields not present. And it will also treat expected fields and components that are not included as not. These are the common message types for HL7. There's one for admission, discharge, transfer. There's one for general clinical order message, imaging order, laboratory order message. So you will notice all the order messages start with an O. With an so for this one, it's OMG for clinical order, general, OMI for imaging, OML for laboratory, OMP for pharmacy or treatment, ORM for general order, and then for unsolicited observation or result, there's ORU. And then unsolicited vaccination record updates, it's VXU. There are those common data types on the coded element used to transmit the codes and associated text, the composite quality with units, the extended address, which specifies the address of a person, place, or an organization, extended person name, the numeric, the string data, the text data, and timestamp. What I'm mentioning here is that there are multiple message types. These are the common message types. Under that, there are multiple data types for the messages. So as much as possible, HL7 tries to be very, very specific so that when you have to exchange your health information, that is easily understandable by one health facility to another health facility. Let's go to an example. So for this example, the immunization message syntax shows the different messages, and this one is for an unsolicited vaccination update. You will note that abbreviation for this one is the VXU with a VO4 component. For this message header segment, it is required, okay, which every message begins with MSH, with the software being optional, and the patient identification segment is required. Every VXU has a patient identification segment. The PID may have a PD1 segment also, which is additional demographics. So RE, what is RE? RE is required but empty. And then the next of kin and associated parties may have an NK1 segment.
Email ya.
So for this one, you will also be looking at the different optional components of the message. For the common order, it's required but empty. And the timing of the order for that particular patient. The patient's treatment for pharmacy route and the observation and the notes, they are required but empty as well. Another example, this one for surveillance message. In this example, what do we see? So what we see, I mean, without looking at the text above the message, you will note that there is a patient that was admitted, ADT. So ADT A1, which is on emergency department, and that patient is female, which is the sex of the patient, and the patient is white. You will see all of that in the patient identification segment. EVN is the event segment, and then going back to PID, which is not Hispanic. So when you describe this, we are seeing a non-Hispanic white female, which is what we see here, not Hispanic white female. For the age, that's an additional for the PID segment. This is the emergency department complaining of stomach ache. You will see that in the observation segment for the chief complaint, stomach ache. The age of the patient as required is seen in the observation here, 43. The patient's temperature is also recorded 99.1 degrees Fahrenheit, and the oxygenation, blood oxygenation is at 95%, so observation. So all of this happened when February 15th, which is the observation here on illness or injury onset date time. You will note that it is on February 15, 2011. There's a diagnosis of an unspecified abdominal pain. There's the acute appendicitis. That's also the impression for this patient as the patient is admitted to. So really, if you without looking at the text and just going into the particular HL7 message, you'll be able to understand what is happening, and what triggered that particular information to be exchanged and to be generated. That's just a very, very quick overview of what happens when health facilities exchange information from one facility to another. I hope that was a helpful overview on the introduction to HL7. Thank you so much, and I look forward to answering your questions.
Okay, thank you, Dr. Raymond, for your presentation. Untuk baik bagi para peserta, Bapak dan Ibu sekalian, bisa menyimpan dulu pertanyaannya atau bisa diketikkan di chat. Namun untuk sesi pertanyaan akan kita fokus ke belakang. Jadi ada satu sesi lagi yang membahas spesifik tentang FHIR, yaitu salah satu versi terakhir yang terbaru dari HL7, dan memang nggak begitu baru banget seperti itu. Tapi ini yang akan kita gunakan di Indonesia dan beberapa negara lain. Okay, for Dr. Philip, you can start your presentation. Time is yours.
Good morning again. So I think thank you, Dr. Raymond, for giving us a introduction to the HL7 standard. So we have to understand that it's important for us to know what HL7 first is before we can appreciate HL7 FHIR. So for this discussion, we will try to give a non-technical introduction to FHIR. We know that there are some participants here that are non-technical and who want to have appreciation of the standard. So that's what we'll do now. For the next session, especially for next week, that is the time when we will be looking at the technical aspect of the FHIR standard. Okay, so I hope you bear with me for the next 1 hour. So what will be our agenda for the next 1 hour? So number 1 is to introduce to you the concept of HL7 FHIR or FHIR. And then number 2, I would like to discuss when is it feasible for us to use FHIR and when it is not very feasible. And number 3, I would like to discuss what will be the benefits for us if we will be using the FHIR standard. Okay, so moving along. So I think during the last session that I had, I was able to emphasize the importance of having interoperable digital health systems. Okay, so and this is not only for COVID-19, but rather, I think this is also important even after the COVID-19 pandemic, especially once we start facing universal health coverage again. So interoperability is a requirement to achieve universal health coverage. We know that every country in the world right now is trying to attain universal health coverage. Okay, so the WHO have said that one of the tools that we need in order for us to reach universal health coverage is actually interoperability. There should be an interoperability of systems, of health systems, for us to attain UHC. So that is a very important conclusion that was made. Okay, so why is interoperability important? Interoperability is important because countries all over the world right now are implementing their respective health information exchanges. So what is a health information exchange? Basically, a health information exchange is an ecosystem. So it's a collection of different information systems with the goal of sharing information, with the goal of sharing patient information within that ecosystem. Okay, so there will be physicians who will do their referral. There will be hospitals which will need their respective medical record. There will also be laboratories imaging that will need to submit their respective results to a health facility. So as we can see here, there are different organizations that will need to share patient record in order for the health information exchange to work. Okay, so well, this is a generic diagram for an HIE. For Indonesia, I think we are all familiar with this diagram. Let me show to you the next diagram. For Indonesia, we are implementing our own health information exchange. So we know that data from EMR, data from all records, we want to connect it with DHIS2, we want to connect it with BBJS, and we want to connect it with various COVID-19 indicators. Okay, so this is an example of a health information exchange. And as I mentioned earlier, for us to attain, for us to be able to have a health information exchange, we need to have interoperability. And if you were listening to my earlier presentation, interoperability is defined to the capability of software systems to share data with one another. Okay. However, take note that there are actually levels of interoperability. So when we say two systems are interoperable, there's a certain hierarchy. Okay. So number one, are they syntactically interoperable? So when we say syntactic interoperability, this is the capability of software systems to process data that was shared to it. Okay, so I would like to highlight the word process. So when we say syntactic interoperability, two systems can process the data that is shared to it. There is what we call semantic interoperability. When we say semantic interoperability, it brings interoperability in a higher level. So when we say semantic interoperability, this is the capability of software to understand the data that is shared to it. So for syntactic, it only processes. For semantic, it understands. So it's a higher level. Okay? And then when we say workflow interoperability, this is now the highest level of interoperability. This is now the capacity of software to work together with other software systems. So the first one, when we say syntactic, this means to process. When we say semantic, this means to understand. And when we say workflow interoperability, this means software will be able to work together with one another. Okay? I hope that is clear. We want to focus on syntactic interoperability first. Okay? Because the FIRE standard is actually part of syntactic interoperability. Okay, so we want to focus here first. So I will just repeat what Dr. Raymond, what my colleague said earlier. So ISO7 International is a not-for-profit organization that is accredited to develop standards for the sharing, integration, exchange, and retrieval of electronic health records. So all over the world, when we talk about sharing of health records, the only standard that is being recognized is the standard that is released by ISO7 International. Okay, and they are a not-for-profit organization. So I think right now, there are quite a number of organizations that are international affiliates. So when we say international affiliate, they meet regularly to discuss the various ISO7 standards. So why is it called ISO7? I'm not sure if it was mentioned by Dr. Raymond earlier. It is called ISO7 because the standard is in the 7th level. So 1, 2, 3, 4, 5, 6, 7. It's in the 7th level of the ISO communication architecture model. So the ISO communication architecture model specifies the various components of information systems that information system need in order for them to communicate with other information systems. Okay, so the lowest level is the physical level. So basically, it's like having a USB or a diskette. If you have used a disk before, you get the data from one computer and you transfer it to another computer. So that's physical. When we say data link, we connect them together. When we say network, we use the internet, we use the network to share data. ISO7 is in the application layer. It's in the highest layer. For that supports the communication of various information systems. Okay, so that is the reason why the name being used is HL7. It was mentioned by Dr. Raymond earlier also that the earliest, the most popular standard before is the HL7 V2 standard. During its peak, during the early 2000s, I think around 70% of all information systems around the world are actually using HL7 V2. Okay, so HL7 V2 is a messaging standard. I want to highlight the word messaging because basically it's a way to send message to other information systems to exchange clinical and administrative data. So it was shown earlier. So this is an example of an HL7 version 2 message. So we can see here that the first line, as mentioned earlier, is the message header. The second line shows the patient ID, the name of the patient, the birth date, and the address. Okay? And then the bars here, they have their own meaning that is defined by HL7v2. Okay, so if you want to use HL7v2, you have to be familiar with the various notations that are in the messages. Okay. And then during the early 2000s, HL7 version 3 was developed. So again, version 2 is a text-based messaging system. So you have a text file that is very long. Version 3, as you can notice, is an XML-based system. Okay, so instead of putting everything in one text, you put them in an XML file. So if you are, so I think many of us here are programmers, and we are familiar with XML files, we know that it is easier for us to program if we will be using version 3, if we will be using an XML file, versus using a text file. Okay, because when we use an text file, we need to parse the data. So we need to know, we need to count how many pipes, how many carrots, and then we encounter a name, and then how many pipes, we encounter an address. So I think if you are a programmer, you know that it is not very easy to do. If we have an XML file, then we can use the document object model. So if you are using Java, and we can already easily get the data in the XML file. You just need to know which tag to get. And now here comes Fire. Unfortunately, HL7 version 3 didn't become very popular. Okay, I will be showing a graph later, but as compared to HL7 version 2, HL7 version 3 was not used widely. Okay? During the early 2010, 2011, 2012, Graham Grieve. So Graham Grieve is a Australian digital health specialist. He was discussing with the HL7 community. Why is version 3 not working? Why is it not being adopted internationally? And then from their discussions, Graham Grieve had an idea. What if we incorporate the HL7 standard to existing web standards? During those times, those were the times when REST APIs are becoming popular. So, Graham Grieve proposed a standard that will be based on REST APIs. And that is where the FHIR standard came along. It is a standard that is based on REST APIs. Okay? In this graph, we can see, as I mentioned earlier, the HL7 v3 standard didn't become very popular. So the HL7 v2 was very popular. After it, we had the HL7 CDE, which is another version of HL7. And then this was the early days of HL7 FHIR. During those days, East on Heaven Fire was not yet very popular. That was in 20, this graph was from 2013. However, it was estimated that 10 years after, 7 years after, East on Heaven Fire will already be the most dominant standard. And I think so when we created this graph in 2013, we were here. I think now we are here already. So worldwide, East Heaven Fire is already the most widely used standard. We have here a map of various countries that have their respective East Heaven Fire servers. Okay. We can see that this standard is very popular in Europe. It is very popular in the US area, particularly in the East Coast. And I think one thing that is surprising, East Heaven Fire is actually popular in the Southeast Asian region. So our lab has been working with the Philippines, with Thailand, with Laos, with Indonesia, of course. With Nepal, and even as far as Uzbekistan, we have been working with them, and we have been training them with the fire standard. So I think there's really a strong popularity of the fire standard regionally, and later on we will try to discuss why this is very popular in the Southeast Asian region. But yeah, as we can see, there's really a wide usage of the fire standard. Why is it so? One reason is that the largest IT companies in the world right now, I think this was mentioned by Theo or Aldidas, the largest IT companies in the world right now are using the fire standard. We know that Apple has been using fire for Apple Health. We know that Epic, which is one of the largest EHR provider in the US, they are developing, they have developed their own fire platform. Google is also using fire. Microsoft, Azure, Amazon, they are all using fire. So the largest IT companies in the world right now are using fire as their back end. Okay. So I have been repeating the terminology fire repeatedly. However, I haven't defined what it is. So when we say fire, it means fast health interoperability resources, FHIR. Okay, so that is the meaning of the name fire. Before we continue with fire, so I will stop there first. I will just try to briefly discuss. So basically, fire is on Heaven V2. These are examples of syntactic interoperability. We use them so that the various software can process the data that we have. However, fire is an example of syntactic interoperability. There are, so when we talk about semantic interoperability, or workflow interoperability, there are other examples, okay? So let's now talk of semantic interoperability first, okay? So before we continue with fire, I will just like to spend the next 5 to 10 minutes to talk about semantic and workflow interoperability, okay? So semantic interoperability, as I defined it earlier, is the capability of software to understand the data that was shared to it. So how will a software understand data? This is where coding will come in. If you are, well, I'm pretty sure many of us here are familiar with ICD-10. ICD-10 is actually an example of semantic interoperability, because it provides us with a way for computers. It provides us with a way
Mana itu kalau sebelum pandemi, kalau ketemu Pak Rusdim sudah
Yeah,
nggak salah baik.
way for computers to understand the terminology that we are using. Okay? For example, when we use the term brain, okay? The term brain is an English terminology. Okay? It has a different terminology in Indonesian. In Tagalog, the term brain is utak. So the terminology will have different the term will have a different that part of the body will have a different terminology in different information systems. So in order for us to unify all of them, instead of using the term brain or utak or whatever the term in Indonesia is, we use C71. So this is a universal code that we can use so that any information system in the world, regardless of the terminology, regardless of the language that is being used, when you encounter the term C71, you know that it pertains to that part of the body, to the brain. Okay? Or if we are discussing about diseases like leukemia. Leukemia is a technical term. However, there's a Tagalog term for it. There might be a Bahasan term for it. But again, the idea is, regardless of the information system that we are using, if we encounter C95, we know that that pertains to leukemia. So information systems will now be able to understand what it means. Okay? So ICD-10 is an example of semantic interoperability. Another example of semantic interoperability actually is Lloyd. I think many of us are also familiar with this. So when we say Lloyd, this is similar to ICD-10. However, they are more specific because they have the units. They have more specific definition, but the idea still is there will be codes. Even SNOMED is also an example of that. So these are examples of how we can attain semantic interoperability. However, these are just code, so we need a server to host this code. So that is where the terminology server comes in. So a terminology server is basically a server that hosts those codes. Okay. So that is semantic interoperability. It enables us to understand terminologies from different information systems. So we have syntactic, we have semantic, and now we have workflow interoperability. So what is now workflow interoperability? This is the ability of software to work together. Okay. So syntactic interoperability is to process, semantic is to understand, workflow is for software to work together. And how is this being attained? One example, and I think this is the most popular example of workflow interoperability, is the IHE initiative, the Integrating Healthcare Enterprises Initiative. Basically, what the IHE does is it defines the workflow that will be used by different health information systems. So for example, we have a patient and the patient has an MRI stored in a PACS system and you want to transfer it to an EMR. How will you do that? There are 1,000 ways of doing that. So I can do that one way, you can do that another way, another person can do that another way. What the IHE does is it tells us of it provides to us a standard way of doing things. It provides us with a flow chart. Okay, so rather than doing things differently, we can do things the same way, so that we will be interoperable in terms of workflows. Okay. So IHE provides a set of workflows that can be used by digital health providers. So the idea here is that an IHE compliant system can be able to easily integrate with another IHE compliant system. Okay, so because they will have the same workflow. So how do they do compliance? So basically they do connect-add-ons. So later on, I think in one of our sessions, I will discuss what a connect-add-on is. So just to summarize, interoperability can be achieved via syntactic interoperability. So it is the ability of software to process data. ISO7 FIRE is an example of syntactic interoperability. It can be attained using semantic interoperability. So semantic interoperability is the capability of software to understand data. And finally, we need to have workflow interoperability. So workflow interoperability is the ability of software to work together. We don't need to do all of this. For many countries, attaining syntactic interoperability is already okay. However, you have to take note that as more issues in health comes along, the health process becomes more complicated. That is the reason why eventually we actually need to look at how we can attain semantic interoperability or how we can attain workflow interoperability. So I think when we can now go back to the FIRE standard, so we were able to define earlier what FIRE is. So it means fast, health, interoperable resources. We were able to define that the FIRE standard is actually using REST APIs. And another thing we have learned earlier is that the ISO7 FIRE standard is actually based from ISO7. Okay? So for my next slide, I will be showing with you a video again to briefly introduce to you what FIRE is. Of course, we will be discussing FIRE more deeply, but for us to have an idea, especially for the non-technical people here, for us to have an idea of how the ISO7 FIRE standard work. Okay, so again, this is just a short video, and we just want to give you a very brief overview of what ISO7 FIRE is. So let me play this one. There you go. So I hope we had a very quick understanding of what FIRE is. So I want to go to a particular Let me remove the sound. I want to go to a particular slide here. This one, okay? So let's stop here. So basically, what is H07 star? So to explain it in a very simple way, let's imagine that we are in a coffee shop. So the pandemic is already over. We are now going to a coffee shop to enjoy our coffee. Okay, so we go to a coffee shop, and then we want to order some pastries over here. So we want to order some cake. We want to order some coffee. The idea is instead of us getting the coffee ourselves, or instead of us getting the pastries ourselves, we will ask the waiter to get the coffee for us or to get the pastries for us. Okay, so that is how it works on a normal coffee shop, and that is how APIs work. Okay, so let me. We are API consumers. So we imagine that we are the EMRs, we are the EHRs, and then we want to get data. We want to get information to another EMR, or we want to get data from another database. Usually, when we talk about APIs, we use resources. We talk about data. Okay, so we want to get a resource from another person, from another system. We will not get it directly. Just like in the coffee shop example that we have, we go directly to the kitchen and make our coffee. We cannot go directly to the kitchen and get our pastry. That's the same process in health information system. We cannot access another information system directly. Why is it so? Because number one, we might destroy that information system if we access it directly. Number two, it might be a security issue. That's the same reason in coffee shops. Imagine if they allow everyone to go inside the kitchen to make their own coffee, or if they allow everyone to go inside the kitchen to make their own pastry. Imagine how chaotic it is, right? So that is also the same reason why we need an API. Basically, an API is a tool that will allow us to get data from another system without us going to that system. So in this example, we have the waiter who will ask us of what we want, and the waiter will be the one who will get the pastry. He will be the one who will make the coffee for us. That is also how API works. We specify to the API what kind of data we want, and then the API will get it from us. Okay, so that is, I hope, a very simple, a very non-technical way of explaining what an API is, or well, basically what FHIR is. Okay, I want to emphasize also that another thing that we see in coffee shops is that they usually have the menu. So the menu contains all the pastries that is available and all the drinks that is available. That is also true with APIs. So the APIs, usually they have documentation. So we will be looking later at the FHIR documentation, where we will see what resources are available for that API. Okay, so I hope that's clear. Sorry. So moving along. So fire, as I mentioned in the video, is under, so fire is many things. Number one, it is standard way of describing data format and elements. So fire defined, it provides us with a standard way of with the standard data format of the various elements. For example, if we will be looking at a fire patient, there's a standard format for the name, for the address, for the birth date. Okay, so it already standardizes it. At the same time, the main difference of fire with the other ISO 7 standard is that it also is standardized the way the data can be shared. Because ISO 7 version 2 and ISO 7 version 3 are only data formats. They only define what is the structure of the data. For fire, it defines the structure. At the same time, it also defines the way on how data will be shared. So it brings interoperability in a higher level. So that's why fire is very popular actually, because it already defines how we will get data from another information system. It had an attempt to define a free and open data API, and we will be discussing it later. Okay. So basically, fire is three four things. Number one is a server. Number two is a data model. Number three is a RESTful API. And number four is a collection of tools. Okay. In terms of complexity model, fire is not complex to use, as we will be seeing in my next slide. It's very simple to use actually. However, it's very rich. It contains a lot of information. We can actually process a lot of things with fire. And it's simple. Okay, so it is in this area where it is not complex, yet it has a lot of information in it. Okay. So I want you to look at this table. So going back again, even the non-programmers will appreciate this table. So in this table, we show the different ISO 7 standards. Okay, so we show ISO 7 version 2, and we know that ISO 7 version 2 is a text-based standard. So in order for us to get the name of a patient, we need to parse this text file. Again, if you're a programmer, you know how hard. I know. This is one of the things that we don't want to do. We don't want to parse text files because it's really actually it's not hard, but it's very boring to do. It's very you need to do a lot of things in order for you to program this. So that is on 7 version 2. And then we have ISO 7CA. So basically ISO 7 CBA or ISO 7 version 3, it simplified things. Rather than parsing a text file, you just need to parse an XML file. And you know that is easier to do. As long as you know the tag, and you have a document object model, Java DOM, you can do this. Okay, so that's another thing. And then we go to fire. I think instead of using an XML file or parsing a text file, we just do an API call. Okay? I think many of us are familiar with APIs, and that is how easy for us to get the name of a person using fire. It's a lot easier than ISO 7 CBA or ISO 7 V2. And I think that is the power of the fire standard. It makes things a lot easier for programmers. Okay. So H07 Fire was developed using 6 major principles. Okay, so the first principle is the focus is on implementers. The second principle is we want to focus on common scenarios. The third principle is to use web technologies. That is basically the reason why we are using REST APIs, because they are the most widely used web technology right now. It also supports human readability. I think the beauty with the file standard is you can actually read and understand the file that will be generated. Okay. It makes content freely available. So Fire uses an open source license. And finally, it supports different paradigms and architecture. Okay, so let's look at each of the manifesto listed. Number 1, the focus of Fire is on implementers. Actually, if you will look at the Fire website, it was actually developed for developers. So it is actually very easy for us, for developers, to develop our own systems with the Fire backend. So that was the main one of the principles behind Fire. It made it easier for developers to develop their own applications. Okay. Number 2, and I think this is very important also, it follows the 80-20 rule. What does it mean? If you will be using Fire, if Indonesia will be using Fire, Fire will actually only cover around 80% of the workload or 80% of the data. Why is that so? Because the remaining 20% will be localized. Fire cannot define a 100% standard that will be used by all countries in the world. So there's no thing such as that. Why? Because there are things that are local in a country, and only that country is the one using that. For example, in the Philippines, every form that we are filling up, we usually put our religion, or what is your religion. And that is actually unique in the Philippines. In other countries, they don't do that. I believe in Indonesia, you also don't do that. So that way, that thing, we try to localize Fire with that, because that is not part of the 80% of the common scenario. One thing I learned about Indonesians is that there are Indonesians that don't have a first name or a last name. You only have a single name. Again, that is unique for Indonesia. So for Fire, they don't deal with that. That is one thing that you will have to localize. Okay, so and by doing that, by not imposing a 100% standard, it actually makes Fire more flexible. It actually allows us to localize, and I think we will have a discussion in the future on how we can localize Fire in our respective countries. Okay, so that is what the 80-20 rule is. Number 3 is open. Actually, Fire uses an open source license, and it uses the Apache 2 license. So what is the value of that? Apache 2 is the most open of all open source licenses. Okay, so you can actually use Fire, you can change its name, you can change the logo and put it in your system or without any license. That is how free it is. To give you an idea, in the Philippines, we use Fire for our COVID-19 information system, and we didn't pay a single cent to use the Fire license. totally open source. Okay, so that's another thing that was done in FIRE. Number 4, it supports multiple paradigms and architecture. So I was very excited earlier when Hitayaji was showing the diagram for the integration of the various systems, because I believe that FIRE can easily integrate with that diagram, because FIRE was developed to be architecture agnostic. It means that we can actually use any architecture with the FIRE standard. So what are the benefits of using 807 FIRE? Number 1, and I think this is the most important benefit. It allows System to leapfrog existing technologies. So what does it mean? If I have an information system and I want it to be interoperable, I don't need to follow this step. I can actually leapfrog. I can easily be interoperable by just using the FIRE standard. Okay. So I will be showing to you an interesting diagram. So in 2015, there was this digital health maturity diagram. So they compared internet penetration and digital and EHR adoption per countries. Okay. And unfortunately, the Philippines, Vietnam, Indonesia, India, Thailand, China, we belong to the lower tier. Okay. So in 2015, we were not yet that advanced when it comes to digital health maturity. However, we have to emphasize that the countries in the upper right, that the more advanced countries, it took them years, and when we see years, it took them decades before they were able to attain digital health interoperability. They are mature. However, the investment that they made and the years that it took for them to be able to reach that level is too large. Actually, in some countries, for example, in the US, they are even not yet that fully interoperable yet. And what will help us? What will help us reach that? FIRE will help us. Within 1 or 2 years, if we will be implementing FIRE, then we can easily have a mature information system. That is what Vietnam, for example, is doing. Vietnam started to use FIRE in 2017. By 2019, they already have an integrated infrastructure. Okay, why is that so? Because of FIRE, because it was very easy to use FIRE. FIRE enables us to leapfrog. It enables us to jump so that we don't need to follow the steps that were taken by the other countries. For the Philippines, for example, for the longest time, we had a fragmented health system. Okay, we don't have a national repository of things. And then COVID-19 happened. And then government mandated the use of FIRE. Now, at the very least, we have some integrated systems that we are using. So we were able to do that in the span of 1.5 years. Again, because of the FIRE standard. Okay, so I think that's the main benefit that we have when we use the FIRE standard. It allows us to leapfrog. It allows us to be more mature in a faster amount of time. Number 2, it's very cheaper. It's cheaper to implement FIRE, so we don't need to define our own standards. Basically, it's free. And there are a lot of open source tools that we can use. And I think there was a question earlier about 807 version 2. Another benefit of FIRE is that it is back compatible. So it is easily compatible with version 2 or with CDA. So if we are using version 2 right now or CDA, Fire is easily compatible with that. So we can actually upgrade to Fire and upgrade our data with it. And lastly, Fire can actually work in countries with varying degrees of capacity. We don't need to be as technologically advanced as India or as the US or as Singapore or as the US Fire. Okay? As I was mentioning during with Akio earlier, we only need the basic training. We only need this training, the one that we will be doing within the next 4 days for us to implement Fire. We don't need to be super experts. Okay? Based from our examples based from our experience in Phil Asia, we have been working with Vietnam, with Laos, with Thailand, with Uzbekistan, and we have seen that they have different capacities. However, all of them, they are all trying to use Fire so that they can defrag. So I think the concern that we have in Indonesia, that we have very limited capacity, is not really a problem. Because as I mentioned here, Fire can work with countries with varying degrees of capacity. We only need some training. We only need to know what we will be doing. And we only need to know the people who will go to the experts. And from there, I think we can already implement Fire nationally. Okay, so I think for the next 20 minutes, I will be discussing the Fire data model. So what is the structure of the data in Fire? So I think this is very important for us, especially as we move on to next week. Okay, so Fire has basically 150 resources. So what is the meaning of a resource? A resource is basically the building block of Fire. So this is the basic data model in Fire. And right now, it has around 150 resources. If we will be going, so let me go to the Fire website. Okay, so let's go to the Fire website. As you can see here, we can see here the various resources that are available in Fire right now. So these are the basic data in Fire. So we have, of course, the patient practitioner. So when we say doctor, when we say laboratory technician, nurse, they are practitioner. We have care team, we have device organization. When we say organization, this will be the health facilities, the laboratories, location. And then we have clinical related resources like allergy, procedure, family history, etc. We have diagnosis. So we have observation, report, specimen, medication, workflow, even financial. So if there are people from BPJS here, Fire can actually model claims, it can model invoice, it can model coverage. So I think Fire has a lot of resources that we can actually use for us to further understand, for us to further model our clinical workflow. In one of the sessions that we will have, I'm not sure if that will be this next week or the following week, we will have a discussion on Fire clinical modeling. So Dr. Raymond will discuss how clinical scenarios can be modeled using the Fire standard. So yeah, so these are the examples of the Fire resources. And take note that there are some non-examples. So for example, gender is not an example of a resource because that is very small. Electronic health record is also not an example because that is very big. Blood pressure is too specific, so that is also not an example of a resource. Intervention is too broad, so that is also not an example of a resource. So I think it's not a good time for us to look at the patient resource. So if we go to the FAR website, we can, so again, before I continue, I would like to go back to the analogy that we had earlier. So remember the menu in the coffee shop. So the menu shows to us what things we can order. Basically, that is what the FAR website does. It shows to us the things, the resources that we can use in FAR. Okay? So let's look at the patient resource. So the patient resource, it shows to us the various information that is associated, that we can associate in the patient. For example, name. It has name there. It has telecom. So FAR already standardized the data content that we will need. Okay? So I will again go back to the developers in the room. So I think many of us here already have experience developing our own systems. And one of the first things that we do when we develop a system is we design the database. Okay, so we usually design the database. And when we design the database, what do? We identify the tables that will be in the database. We identify the database schema. We identify the database elements. Okay, so those are the things that we do when we develop the database design. With FAR, if we will be developing a app, we don't need to design the database anymore. We can already use the FAR standard as the basis for our database. Next meeting, we will see that we don't actually need to design our backend anymore. Because FAR already has a backend that we can use. It already has a database that we can use. So that is how easy it is for us to develop applications using the FAR standard. Okay? So it already defines the name, the gender, what gender, the birth name. We already have the fields that we need to fill up. And then we can see here, we have here the flags. It shows that the patient resource is already a normative resource. So what do we mean when we say it's normative? It means that it will no longer change. It's already very consistent already. So the things that we will see here will no longer change. It will only change if the H07 community approves that. But generally, it's already that. It's already constant. Another thing that I want to emphasize here, as you can see in the cardinality, so we can see here in the cardinality, for example, for identifier, a patient can have 0, it can have no identifier, or many. In database system, when we see the asterisk, it means many. Okay, so we can have 0, it means nothing, or many identifiers. When we say active, this means the patient is either active or inactive. We can have 0, it means none, or we can have 1. We can have 1 status, either active or inactive. With name, the same thing. We can have 0, or we can have many. It's possible for people to have many names. Okay? So if we will be looking at all the fields here, what do we notice? Almost all of them begin with 0. So that means that actually another thing with the H07 FAR standard is that it tries to minimize the data that it really requires from the users. Why is it so? Because it wants to be as flexible as possible. If we require something there, then that means everyone who will be using the patient resource will have that field. So that will be a constraint. So with fire, try to be as flexible as possible. You can actually have a patient with no name. That's okay with fire. So I think that's an important thing that we have to remember. So we don't have any required fields in fire. I want to also go to I want to briefly show to you the website. So when we I hope that within the next week we will be looking at this website. We can actually look at examples. Okay, so for example here we have here some example patients. We can look at it using the XML format or using the JSON format. So if we will be looking at it with the JSON format, we can already see here the output of a JSON resource of a patient resource in Fire. We can see here the patient name. We can see here the. So you see, it's possible for us to have a patient with many names. We can see here the telecom and those things. So I hope that during this week we will be able to look at the Fire website in a deeper way. So going back, so a patient is contained several components. So in Fire, aside from resources, so we have a resource, and then the resource has several components. There are two types of resources. Of components. The primitive data type and the composite data type. When we say primitive data type, these are the very basic data types. So if you do programming, so we are familiar with the data types. String, integer, those things. So Fire also has that. So it has a string, it has Boolean, it has date. It has URI if you want to enter a URL. It uses base64 also. It also has date time. Okay, so these are the primary data types in Fire. We also have composite data types. So when we say composite data types, these are combinations of primary data types. So one example is the name. The name is a composite data type because it is a combination of strings. Okay, the name is not a resource. It is specific and it is not related. So it is not a resource, it is not a basic data type. It is basically a composite data type. Coded type is another example of a composite data type. So we can see here the code and the source of the code. Attachment is also an example. Quantity, so we can see here the value and the unit. And even the source of the unit, we can see it here. So we are now almost ending. So for the next meeting, we will see how we will combine the various resources so that we can generate better understanding of a clinical workflow. Okay, so the challenge with Fire is how we can put them together, how we can put the resources together to form a story. So we usually combine resources in Fire to get a more definitive story. We will be showing that in our next presentation next week. So in Fire, each resource has an identifier. So it's basically the ID. So how do we get data in Fire? So we use an endpoint. So the endpoint basically is the URL of the Fire server that we are using. In our example here, the Fire server that we are using is the Happy Fire server that is hosted in the Happy server cloud. So here, let me get out of sorry. So here, if we will exit full screen, so we have here the URL. So this is the base URL, and we have here the resource. So this tells us what resource we are getting, and we have here the ID. This tells us the ID of the resource that we are getting. Okay, so if you can actually so what I will do, I will try to let's try to go to that URL. So what I will be doing is I will be copying that URL. This one, so I will be copying this to my browser. I will also be sharing this via chat. If you want to access what I will be accessing, so I will be sharing this via chat as well. So you can try to access that. So let's see what we will get from that. Unfortunately, the server that is being used is slow today, so let's try to wait. Let's try to access the server first. Okay, so let's access that later. But the server that we're using is actually slow today, so maybe there's a lot of people accessing it. So let's try to access that in a later time. However, the idea here is that for Fire, you only need to know the resource that you want to access and the identifier, and that will enable you to get data already from a Fire server. Okay, so that's one thing. So once unfortunately we can't load it now, but once if ever we were successful on loading that, what we will get basically is a resource. It has a metadata. It has the extension, it has the narrative, it has the body. So basically it appears like this. If you are able to download data from a Fire server, you will see the metadata. So the metadata basically shows to you the resource of what you are accessing. It will show to you the ID. It will show to you the version of the ID. It will also provide to you a human readable narrative. So basically, if you can see this is an HTML file, so if you will be loading this in the browser, you can actually understand it easily. So that is one of the principles of Fire. It has to be human readable. And finally, you can see here the body already. So you can easily see the body of the resource that you are trying to access. So you can do that in JSON. You can also do that in XML. So Fire supports both JSON and XML. It also supports Turtle if you are using Turtle. Basically, that's it for now. So for today, I hope that we were able to have a brief introduction of what H07 Fire is. I hope you were able to see the benefits of using Fire. I hope you were able to see the benefits of having an interoperable digital health ecosystem, and you were able to see how Fire will be able to support that interoperable data system. For next week, we will be covering number 1, Fire architecture. So we will look at various architecture and see how Fire can be used to it. And then we will have one parallel session next week for the clinicians out there, so for those that are clinicians, I think the fire modeling session, which Dr. Raymond, who is also a clinician, will handle, will be very helpful for you. So you will be able to see how we can use fire to model our clinical workflows. And for the non-clinicians, for the IT people, we will be discussing fire APIs. So this one, basically, we will be studying this more. We will try to see how we can download data from a file server, how we can push data to a file server, how we can delete data, how we can update data, how we can search data in the file server. So those are the things that we hope to cover by next week. So I think the floor is now open for questions.
Oke, thank you for the presentation, Dr. Philip. Ya, ini sudah ada beberapa pertanyaan yang sudah masuk. Namun sebelum itu, kami sudah mengirimkan link untuk pendaftaran sesi minggu depan. Jadi, ya sesuai yang dijelaskan Pak Tio sebelumnya bahwa sesi selanjutnya yang akan diadakan setiap hari Sabtu hingga tanggal 11 Desember itu akan kami khususkan untuk beberapa undangan, termasuk dari teman-teman dari Pusdatin, DTO, dan juga beberapa teman-teman di rumah sakit pemerintah di daerah, dan juga rumah sakit vertikal. Ya, sehingga dimohon untuk mengisi formulir tersebut jika ingin mengikuti sesi berikutnya, dan akan kami adakan hingga batch 2, yang batch 2 yang nanti akan diadakan lebih terbuka, lebih umum di bulan Desember. Seperti itu. Jadi jika ada ketertarikan, mohon isi survei dan akan kami beritahukan melalui email untuk pengumuman selanjutnya. Oke, ya. Ada beberapa pertanyaan yang sudah masuk, jadi akan saya bacakan dulu dalam bahasa Indonesia. Jadi ini ada pertanyaan dari PT Trilux. Ya, untuk data message, contoh data message yang dijelaskan Dr. Raymond sebelumnya, itu ya termasuk yang baru ya, mungkin baru melihat untuk teman-teman di programming karena terkait dengan terminologi. Ya, karena ada banyak terminologi yang bisa diadopsi seperti SOMET dan juga LOIN, dan juga, nah bagaimana kira-kira atau mungkin rekomendasi dari Dr. Philip dan juga Dr. Raymond jika Indonesia ingin mengadopsi terminologi tertentu atau ya terminologi itu akan diserahkan kepada komunitas di Indonesia, dan apa yang akan terjadi dengan legacy system yang sudah ada, dan juga how fire best practice editor handling this. Okay, so I will read in the English. So for Dr. Philip and Dr. Raymond, we also noticed that there must be massive data of terminology as data standard. Then back to Dr. Kerdian question, how we handle this terminology standard and what will happen to the hundreds of legacy systems that may have different terminology standard, and how Fire HL7 will handle this problem. Okay, maybe that's the first question for Dr. Philip and Dr. Raymond.
Yeah, I will answer first, but so one of the things with Fire is it can actually handle multiple terminology. So in the example that I'm showing right now in the screen, we can see here that we can use for headache, for example, so we know that there are different terminology services that we can use to code headache. So for ICD-10, it uses R51. We can actually put it here. And if we will be using SNOMED, we can also put it there to display the same value, but with a different code. So if Indonesia will be using a different terminology, then we just need to put it in our Fire resource. and we just need to identify the URL or the link for the terminology server for that terminology. Yeah, so, and even if we were using previous terminologies before, we can add it also in our Fire resource so that we can still access the previous terminologies. So I don't want remote will be presenting its discussion on terminology, but that is basically how terminology services work in Fire. Dr. Raymond, do you want to add some more?
Thank you, Philip. The terminology services allows you to be able to do mapping as well as some sort of aggregation for all of your existing terminologies. What I mean is that if Indonesia is using something that's very unique to Indonesia, and you are also in conjunction would want to adopt something like SNOMED for clinical terminologies, and then ICD for diagnosis, and then maybe LOINC for your laboratory terminologies. Those things could be stored in a terminology server so that whatever concept is inputted, that will also be mapped already to the concept for that particular terminology listing. So for SNOMED, this is the code. This is for ICD, that's the same, etc., etc. Having a terminology server allows you to be able to do all of those things in one using one platform, and that will be very very easy, assuming that the governance group mandates the use of a terminology server. That will be easier for the healthcare facilities to be able to utilize, and that's something that will be very very similar to how they do it in Canada and Australia, and also for the app model that I mentioned earlier.
Oke, thank you Dr. Raymond dan Dr. Philip. Jadi pendeknya memang ada layanan terminologi service yang memang bisa digunakan secara nasional untuk menyeragamkan terminologi yang dipakai di masing-masing sistem seperti itu. Namun kembali ke kebijakan di pusat seperti itu, kalau tidak salah kita punya health data dictionary yang mungkin sekarang masih dikembangkan dari pihak Pusdatin, dan mungkin itu yang akan digunakan sebagai terminologi, dan kita tunggu, kita akan banyak berdiskusi nanti di workshop mengenai terminologi yang bagaimana yang akan digunakan di ke depan bersama dengan DTO juga. Baik, ya pertanyaan selanjutnya, ya. Kalau dari Yasir Muhammad, sepertinya pertanyaan sudah dijawab oleh Pak Setiaji. Jadi tidak ada data yang dikumpulkan terpusat. Jadi disebutkan tadi contohnya di EHR nasional yang sedang dikembangkan DTO bulan ini, mereka akan mengumpulkan data resume medis yang itu bisa digunakan untuk klaim ke BPJSK seperti itu. Kemudian ya penjelasan selanjutnya dari Pak Hadi. Ya, apakah bisa kita integrasikan framework bahasa pemrograman yang ada dengan Fire, contoh Laravel dan beberapa framework lain dengan Fire, dan apakah ada resource atau library untuk mengintegrasikan hal tersebut? So the question from Pak Hadi is for Dr. Philip and Dr. Raymond. For the system may use various framework like Laravel or Django, and how they integrate it with Fire, and is there any separate resource or library to integrate those framework into Fire?
That is
Maybe Dr. Philip or Dr. Raymond.
That is a interesting question. So, Fire was developed in such a way that it is architecture agnostic. So what do we mean by architecture agnostic? is not dependent on any architecture. Okay, but even if you are using Laravel, if you are using Django or CodeIgniter, or even if you are using any web framework, you can still use Fire in it, because Fire is only a methodology to get data from a database. Okay, so for example, if you are using Laravel in your model, right? So since Laravel follows the model view controller framework, in your model, rather than defining your own query to the database, you can already use the Fire API calls that we will be discussing next meeting, so that you can still use Fire even if you are using the Laravel or the CodeIgniter framework. If you are using Django, it's the same. When you do your query to your database, rather than doing a direct SQL query, you can use the Fire call that we will be discussing in order for you to get your data from your database. So the framework that you are using should not be a challenge or a hindrance when we use Fire. And another thing, lastly, Laravel, CodeIgniter, Django, those are frameworks that are being used to develop single applications. Okay? However, Fire is usually used to integrate multiple applications. So it's in the integration of applications where Fire has its value. So even if you have a system that was developed in Laravel, or you have a system that was developed in CodeIgniter, or you have a system that was developed in Django, as long as they are using the Fire standard, they should be able to integrate with one another. So yeah, I think that's the answer to the question.
Okay, thank you, Dr. Philip. Is there any addition, Dr. Raymond, maybe?
I think that's what we are stressing. It really doesn't matter what language your information system was created, as long as you follow the standard given the particular resources and all of the, let's say, the rules that governs how Fire message is exchanged. It doesn't matter really at the end of the day. It will be able to communicate between the two systems.
Oke, thank you. So, jadi rangkumannya adalah mau menggunakan framework apapun atau bahasa pemrograman apapun, sistem yang Anda kembangkan, jika sudah secara nasional sudah mengadopsi satu standar pertukaran data, maka akan bisa berkomunikasi dengan sistem yang di antara di pemerintah maupun antara dengan sistem yang lain. Ya, ya, ini ternyata Pak Rudi masih bergabung dengan kami dari Pusdakin. Jadi izinkan saya kembali ke pembahasan sebelumnya mengenai terminologi yang akan digunakan di Indonesia. Jadi Kemenkes telah mengembangkan Health Data Dictionary yang itu digunakan di dalam lingkungan Kemenkes, dan bagaimana prospek kedepannya, apakah masih dapat dikembangkan dan bisa diadopsi oleh pengembang-pengembang sistem informasi yang lain seperti itu. Mungkin Pak Rudi ingin berkomentar, Pak. Pak Rudi.
Ya, terima kasih. Jadi kami sudah mencoba mengembangkan, bisa dibuka dengan dual bahasa. Izin apakah terdengar?
Ya, terdengar Pak Rudi.
Ya, kami mencoba mengembangkan dengan semampu kami ya dari perkembangan itu, dan mungkin ini bisa kita gunakan sebagai referensi, ataupun juga nanti bisa mohon bantuan untuk bisa lebih melengkapi ya. Apakah kamus seperti ini bisa dimanfaatkan dan bisa digunakan oleh semua pengguna nanti yang akan memanfaatkan Fire HL7 Fire ini. Mungkin begitu sih. Terima kasih.
Baik, terima kasih Pak Rudi. Mungkin pertanyaan terakhir ini juga bisa dijawab oleh Pak Rudi. Apakah sistem informasi kesehatan kita akan menggunakan NIK sebagai identity utama untuk di Indonesia?
Ya, untuk single identity kita tetap akan menggunakan NIK, nomor induk kependudukan. Tetapi yang perlu dipahami bahwa aturan dari teman-teman dari Kementerian Dalam Negeri, khususnya dari Ditjen Dukcapil, itu ada aturan. Yang pertama adalah pengakses data kependudukan tersebut harus orang atau tim atau staf yang institusinya sudah melakukan perjanjian kerjasama dengan Kementerian Dalam Negeri. Itu yang pertama. Kemudian yang kedua adalah untuk mengakses itu, kita tidak boleh menyimpan data di dalam sistem. Jadi itu tetap bisa digunakan, tetapi prinsipnya adalah data kependudukan itu bisa digunakan dengan syarat bahwa data kependudukan itu hanya untuk verifikasi dan validasi saja. Jadi tidak diperkenankan kalau misalnya kita ketik nomor induk kependudukan, ada nama dan sebagainya, itu langsung disimpan. Nah, itu tidak diperkenankan. Dan kalau untuk mengakses data itu, khususnya untuk keamanan data pribadi dan regulasi yang ada, itu kita yang mengakses itu harus mempunyai NDA. Jadi memang ini hal suatu tantangan, tapi bukan juga menjadi kesulitan gitu ya. Bahwa banyak sistem yang mestinya sekarang sudah menggunakan NIK itu dengan sistem menyimpan data NIK tersebut. Nah, itu tidak diperkenankan, jelas. Kemudian yang kedua, kita juga harus membuat sistem kita yang bisa melakukan verifikasi dan validasi saja. Jadi data NIK itu boleh diverifikasi dan validasi. Ini tidak menjadi hambatan buat kita. Jadi memang sampai saat ini kami memang sepakat bahwa akan menggunakan data individual itu menggunakan single ID-nya adalah menggunakan nomor induk kependudukan. Begitu mungkin dari kami.
Baik, terima kasih. Sudah sangat jelas sekali dari paparan Pak Rudi. Jadi kita akan menggunakan NIK sebagai single identity untuk pertukaran data dan mungkin akan ada peraturan yang mengatur lebih lanjut. Oke, yeah, maybe last question for Dr. Philip. As mentioned by Pak Setiaji before, we will be able to read the people EHR, electronic record from some hospital, and maybe you could comment about your experience in Philippines on the data, maybe data security issue, or how you will handle the data security issue in Philippines.
Dr. Remo, do you want to take that?
I missed some of the points, Dr. Aldelas. Can you repeat that?
Yeah. So if we manage to interchange, maybe exchange the data, there will be some security issue, maybe data breach or misuse by the hospital or maybe vendors like that. And how hospital or maybe Philippines to prevent that happen or to mitigate the issue.
Okay. Thank you so much, Dr. Aldelas. For security and privacy, those for the Philippines at the very least, I think we are one of 3 countries in the ASEAN region that have already implemented a national data protection law, very very similar to the GDPR. This does not preclude any tasks or activities that's related to exchange of health information, which, as we all know, is considered as sensitive information. In order to ensure all of that, there are three main security measures that the law, at least in the Philippines, lists as requirements. That's the organizational security measures, technical security measures, and physical security measures. For HL7 fire, that involves the technical security measures, and as mentioned, that's really a limitation, well, of HL7 per se, because HL7 does not really prescribe a particular, let's say, encryption level or security protocol that's necessary for health information exchange. That is left to the governance group in order to make sure that all of the necessary protocols are in place. Nevertheless, in conjunction with all of those requirements under the law, and also the advantages of using HL7 fire, all the Philippines healthcare facilities operate under that particular framework, which in effect is very, very similar to how they do it in the United States, which is the following the HIPAA law, which is the Health Information Portability and Accountability Act, to make sure that there are, shall we say, penalties if there are any breaches, and gross misconduct and gross handling, or incorrect handling of the personal information or sensitive information.
Okay.
Um, if I may also add, I will show to you the diagram again. Okay, so I think we mentioned earlier that the ISO7 standard is in the 7th layer, okay? So Dr. Raymond mentioned earlier that one of the perceived weakness of the ISO7 standard is that it does not define security protocols. So that is correct. So HL7 wants to be as flexible as possible. So it does not want to dictate to a country how it will secure the health data, because as mentioned by Dr. Raymond earlier, different countries will have different health security policies. The Philippines, we have our own data protection law. The US has HIPAA, EU has the GDPR, and these are, although they have the same laws, the technical aspects of these laws are different. So HL7 does not want to dictate to a country how data will be secured. So for Indonesia, I think it is important. That's why governance is important. It is important for Indonesia to define its own cybersecurity policies, its own security laws, and since the HL7 standard is in the 7th layer, Indonesia can actually secure the physical layer, the data link layer, the network layer, the transport, the session, even the presentation layer, using its own policies. And it will not have an impact on fire, because fire is on the 7th layer of that stack. So I hope that we were able to answer that question as well.
Oke, thank you Dr. Philip dan Dr. Raymond ya. Jadi mengenai keamanan memang itu diserahkan kepada bagaimana Indonesia untuk manage perlindungan data pribadi. Jadi kita juga masih menunggu penyusunan RUU PDP, perlindungan data pribadi, dan itu juga mencakup tentang data kesehatan yang juga dibahas di RUU tersebut. Dan juga kita juga ada BSSN yang memang mengelola keamanan sistem informasi di lingkungan pemerintah seperti itu. Baik, ya mungkin karena masih ada sedikit waktu, mungkin masih ada pertanyaan yang ingin disampaikan secara langsung, boleh dengan raise hand. Oke, baik. Jika tidak ada, kita cukupkan sesinya dan akan saya kembalikan kepada Pak Tio. Baik, kita setelah sampai di penghujung acara, untuk link materi akan saya kirimkan. Ya, materi bisa di download di Bitly tersebut. Oke, baik. Ya, apakah ada mungkin ada kalimat penutup dari Pak Pandu?
Terima kasih, Mas Aldilas. Saya kira tidak akan berpanjang-panjang. Saya pertama-tama mengucapkan terima kasih kepada narasumber dari Filipina, Dr. Raymond dan juga Profesor Philip atas penjelasannya, waktu untuk memberi penjelasan yang sangat komprehensif. Kemudian juga kepada counterpart utama kita, yaitu Gus Datin, yang dalam hal ini saya lihat diwakili oleh Pak Rudi dan timnya, dan juga dari DPO Pak Setiaji dan timnya yang juga hadir. Kami menyadari bahwa peserta sangat beragam untuk webinar ini. Ada yang sudah sangat canggih, ya, sudah punya pengalaman dalam menerapkan FHIR maupun interoperabilitas standar lainnya. Tapi ada juga yang masih baru mulai. Jadi saya harap untuk teman-teman yang baru memulai tidak merasa tertinggal, dan harapannya memang upaya webinar dan training ini adalah untuk meningkatkan pengetahuan dan skills, kapasitas secara umum, pelaksana atau pengelola informasi kesehatan di instansi masing-masing, untuk dapat mengenali standar interoperabilitas, dan harapannya ini akan berkontribusi terhadap keinginan besar Kemenkes, ya, yang berkeinginan untuk mentransformasi sistem informasi kesehatan di Indonesia melalui digital transformation. Saya kira itu saja, Mas Abilas, Mas Tio, saya kembalikan untuk ditutup. Terima kasih semua.
Baik, terima kasih banyak Pak Pandu atas waktunya dan juga atas penutupannya. Semoga nanti kita bisa mengikuti pelatihan bersama di workshop mendatang, ya. Nanti untuk lebih jelas untuk waktunya, nanti dari tim kami yang akan mengkontak Bapak Ibu semua untuk bisa bergabung, apakah termasuk di dalam workshop gelombang 1 atau di dalam workshop gelombang 2. Tapi secara umum untuk gelombang 1 itu nanti dari sektor pemerintahan yang terdiri dari direktorat di Kementerian Kesehatan, kemudian badan di Kementerian Kesehatan, DTO, Pusdatin, dan juga nanti ada dari BPJS Kesehatan, serta rumah sakit daerah dan rumah sakit vertikal. Itu adalah peserta pada gelombang 1. Sedangkan untuk gelombang 2 nanti bisa peserta dari rumah sakit swasta, rumah sakit jejaring, dan juga dari pengembang sistem informasi rumah sakit swasta lainnya. Seperti itu secara garis besar, tetapi nanti kita akan follow up dalam link yang sudah kami bagikan. Jangan lupa Bapak Ibu untuk bisa mendaftar. Seperti itu. Baik, terima kasih untuk waktunya. Mungkin sebelum kita tutup, bisa foto bersama, dibuka videonya untuk nanti kita foto bersama, dan sehingga nanti kita bisa merekam. Oh iya Bapak Ibu, kegiatan kita hari ini itu terekam semua di dalam channel YouTube dari Pusdatin. Jadi Bapak Ibu bisa search ya di YouTube, namanya adalah Pusdatin Kemenkes. Nanti Bapak Ibu akan melihat rekaman dari hasil kegiatan kita. Seperti itu. Jadi Bapak Ibu yang ingin mereview kembali apa yang tadi kita sudah diskusikan, apa yang tadi kebijakan apa yang ada, itu nanti akan muncul semua di dalam YouTube tersebut rekamannya. Baik, Bapak Ibu, terima kasih banyak karena sudah dibuka. Kita akan foto bersama ya terlebih dahulu. Mungkin bisa dibantu dengan host untuk merekam. Silahkan, Mas Adit mungkin bisa dibantu.
Sebentar Pak, akan saya foto dulu.
Ya. Apakah sudah, Mas?
Ya, halo. Maaf saya diem. Ya, bisa kita hitung. Ya, 3, 2, 1. Sekali lagi. 3, 2, 1. Oke. Baik,
ya. Sudah. Ya, baik, terima kasih banyak. Jadi untuk workshop seperti yang dikatakan Pak Pandu itu bersifat gratis, dan nanti akan for Mr. Phillips it will be very technical, right? Yeah, it will be very technical, so we hope that the IT team from your institutions can join the discussions and for the workshop. Okay. Thank you very much everyone. Bye-bye and have a good day. Thank you.
Thank you. See you next week. Terima kasih.
Terima kasih, Dr.
Terima kasih.
Gunung
Yeah.
gitu.
Terima kasih.
Terima kasih. Bye-bye.
Bye-bye.
Thank you very much. Bye.